Yeah, go for it. Yeah.
Hey, good to see you.
Oh yeah, shit. No, but that's not what I'm looking for. No.
What was that?
No, that's the microphone. Nope. God damn. Okay, mute. Oh wait, that's all on there. Nope. Dang it. Mute. Turn off the Sonos. Woo. Thank you. So I can try and work on this. I mean, I can.
Like their sound.
Well, that's coming from this.
Getting close.
Welcome to, like I said earlier, Capital Factory. Welcome to Power and Partnerships. a production, if you will, a program that is being hosted by our Innovation Council, who are members and thought leaders and just amazing innovators with Capital Factory. And I would like to give a shout out to all of the Innovation Council members that are participating today. I'd like to say thank you to AWS, Baker Botts, Blue Cross Blue Shield of Texas, and I've got to add the C1 Innovation Lab piece of that, right? They're proud, loud and proud. IBM, McKesson, and MITRE. And with that, please allow me to introduce you to the person that's going to introduce the keynote speaker. Please welcome Steve Lenderis.
Hi. So my name's Steve Lenderis. I'm a patent lawyer at Baker Botts, which is an international law firm with about 700 lawyers around the world. And we're so pleased to be part of this today, part of it with our Innovation Council team members that we just heard about. We've got McKesson, we've got MITRE, we've got AWS, Blue Cross Blue Shield of Texas, and IBM. We're really excited about this presentation about promoting partnerships or empowering partnerships, accelerating startups to improve health equity. Health equity is just such an important part of today's and the future of life sciences and high tech. And I think that we really couldn't do better than our keynote speaker, Dr. Brett Giroir. He's seen this issue of health equity from so many different angles. First, as a practicing physician in academia, both at University of Texas Southwestern Medical Center, at Texas A&M, where he was the CEO of the medical center, the Medical Sciences Center, as well as where you may have seen him on TV as part of the national response to COVID-19. He was not only an admiral in the U.S. Public Health Service, but he was the acting FDA commissioner and the administration's testing czar as we rolled out the COVID-19 testing just a couple of years ago. And so with that, I really want to have all of you guys join me in appreciating Dr. Giroir coming to the table.
Well, thank you very much, and I want to thank all the sponsors. And isn't it great for us to be back together again, right? Yes. I mean, this is, Zoom can only get you so far. I really appreciate the opportunity to be here for so many reasons, but I want to start by saying two things, because we have people from all ends of the spectrum here, is that, your jobs may change, but your passions don't. And I have a passion for public health and ending health disparities in the country. And why ending health disparities? It's not based on some moral principle. It's just, you rob the bank because that's where the money is. If we want to improve America's health, you have to focus on the health disparities. And secondly, we're all on the same team. Our positions will change. I've been in academia, I've been in the private sector, I've been in the government. I'm sort of in all places right now, and I'm sure all of you are going to be that way. And at the end of this talk, I want everyone to really understand that we have real challenges, we have real opportunities, and that no matter what segment you're in, you have an opportunity to improve public health. This is absolutely a team sport, and it only ends in the medical care system, but it starts everywhere else. So thank you very much for being here. That screen is out. This screen is marginal. I do have a couple of graphs after we get through some of the heavy stuff. It's all going to be easy, but I'll try to walk you through a lot of this. So if we're going to talk about where we are after COVID, and we have to level set where we were before COVID, and what is our absolute state of America's health. And let me tell you, there was a variation of this slide when I went to Washington. This is why I went to Washington as the Assistant Secretary, as the senior public health official in the United States, is to try to deal with this. Let's face it, our health is pretty poor. We spend 17.7% of our GDP, over $3.8 trillion, the last estimates. That's going to increase to 19.7%, almost $6.2 trillion by 2026. So we are increasing our expenditures for healthcare in excess of our GDP. Now, I like value, right? I don't mind paying for expensive things if I get the return of that value. but we are not getting this. If you look at our life expectancy among our peer, and these are OECD nations, the Organization for Economic Cooperation and Development, we rank 28th in life expectancy, 34th in infant mortality, 33rd in suicide rate, and 32 out of 38 in preventable mortality. And in fact, in 2015 and 2017, I'll talk about 2020, our longevity decreased. Our mortality went up, our life expectancy went down. This is exactly the opposite of where we are. And over 90% of our health expenditures, that big part of GDP, is all based on chronic health conditions. Pretty striking. This is before the pandemic. Now, you don't need to see the individual points here, but I want to point out in this graph, there are 4 quadrants. The lower left are countries that have low health expenditures and low life expectancy. Okay, we don't spend much. We don't have high life expectancy. In the upper left, low spend, high life expectancy. You really want to be there. In the upper right, high life expectancy and high longevity. That's okay. You're putting money in, but you're getting a return. The only country in that bottom right quadrant which is spend a lot and live a whole lot less, is the United States. Okay? So when we talk about inequities and the pandemic, we have to understand where we are. This was a slide I used a lot. It's from 2014, but it's exactly the same today, even worse. In 2014, the Defense Department said 71% of our roughly 34 million 17 to 24-year-olds would not qualify to enlist in the military, the basic military, if they tried. And the reasons were physical fitness, they were too obese, substance use disorders, they had substance use disorders, dependent or addiction, or they were poorly educated. That's not a great place to start with our health. So let's talk about health equity, and we can look at this from many different points of view. The most striking point of view that I look at is not exactly racial inequities, it's really zip code inequities, and this really gets at the heart of the problem. And the point, it's a sad point, with all the information we have on genetics, and we do, and CRISPR, and editing, and we do, the fact is right now, your zip code is more important than your genetic code. The zip code and all the socio-demographic factors that enter that trump anything that relates to your genetic code or your health care. If you look at the red areas, that's where life expectancy is very low, and they're your typical areas, some parts of Texas, along the Mississippi Delta, in Appalachia, in tribal nations in North and South Dakota, and particularly in Native Alaskan areas, as you see in Alaska. The difference between our highest county, about 86.9 years, and 66.8 years, is exactly the difference between the highest high-income country in the world and the life expectancy on the lowest low-income country in the world. In fact, our counties that are in red have the life expectancy of those in Sudan and Afghanistan. When we talk about racial inequities, there's a lot of ways to look at this, and this is only one small snapshot, but mortality is easy to count, and I just want to talk a little bit about that as we enter into COVID. That doesn't look so bad. Racial inequities in terms of mortality between blacks and whites have decreased over a period of time, but they're still about 20% different, okay? And that is persistent, that's rural, it actually crosses socioeconomic barriers. But when you look at these statistics, which are the last one, they do hide some important facts. This is the overall mortality. When you start cutting the data, the side of this graph looks at those over 65 years. What this says, if you're fortunate enough to be African American and live to age 65, your outcomes are the same as non-African Americans who live to age 65, okay? The problem is you don't live to age 65, okay? Under 45 is the same graph, but the 45 to 64 shows that not only is there a very large life expectancy differences between African Americans and whites, we'll talk about Hispanics in a different kind of context, but that life expectancy actually went down over the past many years, and we all know the reason for that, and that's the opioid crisis and drugs. That really reversed, to a degree, violence, but it was really pushed by the opioid crisis. Chronic obstructive pulmonary disease used to be the #3 killer in the US. Now it's accidents, and that's primarily driven by substance use disorders and everything associated with that. Okay, so this is our starting point, which is a pretty poor starting point. It's a challenge. I have positive things coming up, but then we were hit with the pandemic. We are now almost exactly 2 years into the declaration of a global pandemic. There's been 6 million deaths from COVID worldwide. The estimate is it's 18 million people of excess mortality when you actually states. I don't know if we've hit 1 million deaths yet. It's going to be very, very close. The official cases in the United States because of underreporting. I want to particularly note that this pandemic is not political. It doesn't care who's in office, and political slogans don't change the fact that the pandemic is an evolving, therefore difficult to catch up with. We've had waves of the first variants. We've had waves of Delta. We've had waves of Omicron, where we are right now. Population immunity, both from vaccine immunity, natural immunity, and hybrid immunity, is to a level that I think we're going to be in a stable place for a period of time. It's not going to go away. COVID in some form is going to be with us for many years, maybe decades, at hopefully a low endemic level. Endemic just means there's not large outbreaks. It could be endemic at a high level, it could be endemic at a low level. We want to be at a low level where we protect those who are the most vulnerable. I had a pretty good vantage point of what went on in the pandemic. For the first couple of months, I was busy in uniform evacuating people from Wuhan, the Diamond Princess, all the ships, much more involved tactically and strategically, both on the board at FEMA that allocated ventilators, very important. We had 113,000 requests for ventilators. We had 9,000 in the stockpile. You make those determinations. Between March and July, between March and actually Inauguration Day, I met just about every day with the Vice President. There's Tony, Jerome, Surgeon General in the background, briefed the President pretty much every day between March and July. And I can tell you that this was a challenging, a very challenging episode in American history. We had a new virus. We had no vaccines. We had no countermeasures. We did not know very well that it was spread by asymptomatic people, which was the Achilles heel. We had always assumed that it would be a flu pandemic. When I say we, this country, and that you get the flu, you're sick, you get a fever, you know you have the flu, you go isolate. Very different with this pandemic. But I want to talk a few things about the pandemic, but this is not a pandemic talk. This is a health equity and a public health talk. But I want to talk about why some of the things happened in the pandemic they did and where we go from there. Oops, that is not the slide I wanted. Okay, here we go. Okay, so I want to make a point that our pandemic outcomes, in my mind, plus or minus, and this is not directly, reflected, you know, we talked about pre-existing conditions you have. Our outcomes in the pandemic reflected our pre-existing national conditions to a great degree, and I'm sorry slides the AV, but let me just look at this graphically. This is the percent excess mortality in 2020 versus the 5 years previous to this, 2015 to 2019. Of 65 years old and older. The reddish bars were 45 to 64, and the brownish bars are below 44. Now, we had excess over 65 mortality, and so did everyone. But if you look at that red line, what is notably different about chronic health conditions. Much more important than anything else, if you were obese, your chances of mortality were high. If you had diabetes, if you had all the chronic conditions. So our outcomes, as poor as they were, and again, I'm not making excuses here, we can't expect to have poor health and chronic conditions, have a pandemic that targets those with poor health and chronic conditions, and expect our outcomes to be better. Let's look at mortality 2020 versus 2019 in terms of health disparities, and then we're going to get out of the graphs, and it'll make it pretty easy. On the left side is the overall population, which showed in the United States, and this is over here, for the total population, this is deaths per 100,000. Our overall mortality went up about 17%. Now, the ranges of mortality, so Hispanics had lower mortality overall than whites, then African Americans had the highest. But if you look at the change from baseline to 2020, what you saw was, again, significant health disparities. With the overall mortality going up 17%, African American females up 25%, African American males up 28%, and Hispanics were up really markedly, 32 and 42%. Now, we don't know exactly what that is, the reasons for that is. If you look at hospital data, once you're in the hospital, the mortality is no higher, but it's probably a sociologic and economic reason, is that many Hispanics, and again, I'm not characterizing everyone, have jobs that they couldn't go on Zoom from. They had to show up. They were in service industries. They were absolutely, they had to be there, so they exposed themselves to the virus more. They had higher mortality was much higher. Again, where we are in health disparities. In my mind, and I want to show you just a few examples, building on our baseline pre-existing conditions worsened Americans across nearly every parameter. And we have to understand that. And again, this is not a doom and gloom talk. We're going to get to other things, but we have to understand where we're from and where COVID's going to leave us from, because the future is in your hands as innovators, right? And that's why there was always, and there still is always, and I don't think the Biden administration should be beaten up for this. There is an intersection between infection control and overall population health, and that's a spot that's very hard to meet. And that's why it was very multidisciplinary there. Bob Redfield's usually at the end of that table. That's why it was very multidisciplinary from the start. But let me start with this. Let's look at obesity. If you put people in their homes, you take them away from their jobs, you close the gyms, you make people afraid to go out, what do you expect? And I'm just going to give you the bottom line clue of this. The top line is overall weight loss or weight gain. And basically what this says is overall in the United States, 60% of US adults had an undesirable weight loss or weight gain. And by the way, I'm happy to provide these slides to the organizers so that you can have them. Overall, 42% of American adults had an undesired weight gain, and that was an average of 29 pounds, okay? 18% had an undesirable weight loss, and that was 26 pounds. These are dramatic. And as you know, obesity and underweight are associated with almost all the bad health outcomes we have. Cardiovascular disease, diabetes, Alzheimer's, and 8 types of cancer. So we're going to have to deal with this. And all you young people, I'm thrilled to say, what do you call yourself, Gen Z adults? You were no better. 52% of you had a weight gain of about 28 pounds. And of course, you know, if you look at the Texas side of it, those red states now have obesity over 35% of the population. These are things we're going to have to deal with, and I don't mean, you know, we're going to have to deal with the cancers. I hope all of you understand into wellness programs and to get physically active and to reduce that. So I'm just painting that as on this from the World Economic Forum, but this is just from a week ago. We have a time bomb of cancer that's about to explode right now. People did not get screened. If you look at the overall statistics, colon cancer screening was down 30 to 50%. Mammograms were down 20 to 25%. Overall cancer diagnoses in 2020 were down 20%. It doesn't mean that cancers went away. It meant that they're being undiagnosed, which means we are ready for a wave of people who are going to have more advanced cancer, who are going to need more advanced compassionate care because of this. And we've gotten people out of the screening cycle. They can't do screening because everyone has waited so long. There's only so many colonoscopies you can do in a day. So we're going to have to face that. This is an opportunity for innovation. Something that really breaks my heart is overdose deaths. Before I was testing czar, I was the opioid czar, actually, for HHS, because we declared it a public health emergency, and we went all out on substance use disorders. Again, taking it out of the legal system, putting it as a public health emergency, promoting MAT, getting Narcan, having a cabinet meeting at the White House every single week. And we were able to level off. And I was very, very proud of this, actually, to blunt the rise, to level this off. But when the pandemic hit, it's now through the roof for all the reasons you might imagine. Social isolation, despair, loss of jobs, loss of loved ones. Now we have over 104,000 drug overdose deaths. And this is government providing funding to de-risk, but also bang for our buck. In other words, show the difference between those vaccines. It was everyone all working together to make that happen. Similarly in testing. Testing was something that was not on anyone's radar screen. I never knew I would be most famous for wearing my dress blue uniform and sticking a swab up my nose in the Rose Garden in front of the president. To show how simple an at-home test could be because it was mysterious. I literally, there was a big debate in the Oval Office actually about whether I should do this or not, and people were coming down, you can't do this, it's going to embarrass the president, you got to slip the booger out on stage, all these kind of things. And I just thought to myself, and the president didn't say one way or the other, I said, look, Katie Couric did a colonoscopy on TV, right? If she could do that to demonstrate the health effects, then I can stick a swab up my nose and demonstrate to the American people how easy it would be. But there's no question that testing was a great success. And I just want to say that it was an afterthought. And this is the Obama playbook, but it's not about Obama, it's about Obama and Bush and everyone before that. The playbook for pandemics mentions testing only once, and there it is. The FDA can help with drugs and devices, including diagnostic tests and personal protective equipment. That's the playbook. There was no testing because if you have the flu, you don't get tested, right? You get put on Tamiflu now because if it's flu season, you have a cough, you have a fever, you got the flu, right? So testing was not really thought of as a major component. So there was no stockpile, no industry chain, nothing. We had to build that on the fly. But now, by September of our administration, I had sent 150 million of these test cards out to states, rapid tests at $5 a piece. The Biden administration just sent another 500 million. And now we have home PCR tests, these molecular tests like the Obesity test and like Q Health. This is PCR that you can do at home for 30 to 40 bucks a slot. That's going to make enormous differences because not only will we test for COVID, we're going to test for flu and COVID, we're going to test for sexually transmitted infections, we're going to test for all sorts of things that allow cure to be done in the home. If you lower that barrier to people getting a test, and hopefully people like Amazon and McKesson and other people can lower the barrier to getting treatment, it's going to revolutionize how we distribute care to everyone. Telehealth. The public health emergency allowed us to blow through things that we could never do before. And telehealth, I think, is one of the big wins. So before I left, I categorized in my office, we instituted 387 regulatory flexibilities, and 45 of those related to telehealth, 35 from CMS, 8 with FDA guidance, 1 with ACF, that's Children's and Families, and OCR, those are HIPAA people. 30% of FQHC visits occurred by telehealth, right? That's phenomenal. And over 80% of Medicare beneficiaries were offered and accepted those telehealth services. This goes away unless we have legislative change, right? When the public health emergency ends, all these things go away, and we cannot afford that to happen. Telehealth, and then many of you may be the digital health, is a way to the future. The pathway forward to ending health disparities. This is a slide that I put when I was assistant secretary. The first day I was in office, I put this up. It wasn't as pretty, but I had 9 months awaiting confirmation to tell my office, which was the main policy office for public health in the government. I just wanted people to remember 9 words, and this needs to be our guiding principle, and I think they really work. Number 1, health for all. Number 2, health by all. Number 3, health in all. Everybody can understand that. And what I meant by health for all, it's a little bit different than some definitions, but it's pretty close. That is, we have to agree to a principle that we can assure that everyone has a fair and realistic opportunity to optimize their health. That doesn't mean we're in a nanny state controlling everything you do, getting into your family life, but we have to assure that everybody has it fair, and it has to be realistic. It cannot be unattainable. And to me, that's what I believe health for all is. Secondly, health by all, and this is a mechanism, is we have to distribute and democratize healthcare knowledge, capabilities, and delivery. Gone are the days where we need to bring people to tertiary and quaternary hospitals to get care once they need an amputation for their leg. We have to move way upstream, and we have to bring that
into the town, into the community, into the church, into the family, and into the individuals, with everyone working on that. And that means doctors, nurses, that also means agricultural agents, that means everyone in telemedicine and digital health. Everywhere it has to be ubiquitous. And third, we have to prioritize health considerations in all sectors and policy areas. There's not a single thing that goes on in this city or in this country, in this world, that does not affect public health. Okay, you build a building, what does it do? Does it take away walking spaces? Does it take away a divide so people can walk, exercise? Does it create air pollution? Does it do things that destroy the social fabric of a community? Public health needs to be in every consideration. If we're going to have $1 trillion project for infrastructure, public health needs to be part and part to all of that. That's my simple words, and let's talk about how we can do it. First of all, distributed care, I hope this takes off. And I'm not in this realm, but every day you see things that are happening. This was from a couple weeks ago. Teladoc, which is the largest provider of telemedicine, teams up with Amazon. So now you can wake up in the morning and say, Alexa, I need to talk to a doc, I need to talk to a nurse, and it's there. That's zero cost for insurance, up to $75. I didn't know Amazon was sponsoring it. I think it's just phenomenal, because everything we can do to lower barriers, to decrease disparities, so a person who can't leave work to go can get healthcare, absolutely important. Uber, and I'm talking with Uber a lot. Uber is not just going to be limited to transportation. They want to bring tests to you, they want to bring drugs to you, they're going to have an integrated network of healthcare providers that bring everything right there to bring the care to people. These are just two examples of two stellar American companies, or whatever nationality companies there are, I'm going to say American companies, that are in the healthcare space, distributing and democratizing healthcare, and that is the way to the future. I'm a big fan of pharmacists, as the Assistant Secretary for Health under the Public Health Emergency, the PrEP Act, all you lawyers know, is it gets rid of liability, but it also supersedes any state regulations. 95% of people in America live within 5 miles of a pharmacy, and they're distributed everywhere, including high areas of high social vulnerability. So we did a number of things to allow pharmacists. Number one, they could not do COVID testing, but we did a national declaration under PrEP Act that let them do it. When I saw that childhood vaccines were down by 5 million children, we allowed pharmacists to do that. And as a pediatrician, I got a lot of flack for that. But it's much more important to get vaccines in kids' arms than for them to get it from their pediatrician, at least during the public health emergency. Screening and testing at nursing homes to allow pharmacists, pharmacy interns, and externs to actually get the COVID vaccines. These were all things that were done under my PrEP Act authority under the public health emergency. By the way, they go away if the public health emergency goes away, because that PrEP Act goes away. We've got to keep all of these things. And where would I go? And this is what I would have done if we were in office. I would have extended, and it was a federal overreach, granted, but there is no reason why HIV needs to exist in this country. I was shocked when I was preparing to go to office. We have 40,000 new cases of HIV every year in this country, and I asked the question, why? And the only answer was because no one decided we were not going to have 40,000 new cases of HIV in this country anymore. I briefed the Secretary on it, Tony Fauci and myself and Bob Redfield. The Secretary was all for the initiative. We briefed the President, and that's how we got in the State of the Union in February of 2019. But it's a very simple thing. Is 1 in 2 people with HIV have the virus for 3 years before the diagnosis. 1 in 5 are diagnosed with advanced disease, AIDS. This is not 1980. So let's empower pharmacists to not only do testing, but if you're negative, put you on PrEP right there so that you can prevent from getting HIV. And if you're positive, don't wait 3 months for employment, put them on antiretroviral therapy. Remember, if you're on antiretroviral therapy and you have undetectable levels, there has not been a single case of a person who's undetectable who's transmitted the HIV virus. Why don't we do that? That's an idea for distributed healthcare. Okay. We're winding down to the last part. This is a very important slide, which you probably can't see. This is not a political framework. This is the Robert Wood Johnson framework for overall health in America. And what I want to point out is clinical care, which we spend trillions of dollars on. Access and quality of care only adds up to about 20% of our health outcomes. Remember all those health outcomes we talked about. Much more importantly are what we call the social determinants of health, the physical environment. I talked to you about air and water quality. housing and transit. These are things that have to be built into the cities that a doctor cannot control, a nurse cannot control, a pharmacist cannot control. Social and economic factors, education, employment, income, family, social support, community safety. That's twice as important as the actual formal medical care system. If we want to change our underlying pre-existing condition, we have to change these factors. And I would argue that health behaviors, they're categorized in a different category. Tobacco use, diet and exercise, alcohol and drug use, sexual activity, these are all from social determinants as well. You want to know what's the biggest predictor of opioid outbreaks in the community? Is when their major employers bust and people become unemployed. When the factories for auto workers went down across the country, the overdose rates, death rates in those communities went up 95% within the next 6 months. We all know that alcohol and drug use are dependent highly on the social determinants of health that are in the lower part of this. So about 80% of what we really need to deal with are nothing to do with medical care, and we have to face this. I try, we try, and we all have to try. But before I get into that, I love this. I was at the World Health Organization. I was the U.S. representative to the WHO, represented the U.S. And we're in Kazakhstan for a conference to affirm the importance of primary health care. We have a Red Cross. They don't have a Red Cross. They have this cross because they want, and they have a national network of polyclinics. They want people to know that medical care can fix you about this much, and that's what you're here for. But the rest is health behaviors, genetics, and the environment. They want it to be really clear to people that we will take care of that little red part, but you've got to do your part, and everybody else has to do their part to improve health. So we started very early on the social determinants of health. I was confirmed in February 2018. We had a National Academy study out in April of 2019, and I know Blue Cross is here and you're probably all over this. It's how do we create the business case for the social determinants of health? And I don't mean just provide transportation to people, which is important, but everything else. How do we have housing interventions, kindergarten, schools, all those sorts of things that are critically important to that health matrix I talked about. Healthy People 2030. If you don't know about Healthy People 2030 is the report card. Every 10 years it comes out about the health metrics that the country needs to achieve. There are leading health indicators. There are 350 metrics. There are 41 leading health indicators. This came out of my office. It was a gargantuan lift. But for the first time, our national report card has social determinants of health in there. If you look at the green lines, and you can't read these, exposure to unhealthy air, household food insecurity and hunger, fourth grade students whose reading skills are at or above the proficient achievement for that. These is the health report card. That's how serious we are. And I will just make one other unabashed ploy is we have to have a big policy lever too, and that's changing from our fee-for-service system that rewards the whole healthcare system for that amputation once you have diabetes to a value-based system that rewards for health. This will get the government, the state, the insurers out of doctors and nurses' laps and out of their typing all the time, and will reward them for keeping people healthy as opposed to billing for procedures that they do. This is a major big step that has to happen in our healthcare system. It may take a decade to do, but this has got to be in your mind. If we reward for value and not for treating sickness, that is the big policy lever that we need to go along with all the theoretical. And I would say, which is obvious, is I certainly agree with supplemental appropriations for Congress, but you can't fix 300 years of health disparities with a couple of supplemental appropriations. This is hard work. It's going to take a long time to get it done, but there's some things we have to do. We end with a couple things about innovation. I was at DARPA. I ran the science audit at DARPA. Very unusual for a pediatrician to make a change to DARPA. It's a long story. I do think we need another internet moment for our healthcare system and our healthcare delivery. I love this chart because that was the internet in 1969. It was put literally on a cocktail napkin, was the description of what the internet was going to be. That was a very important moment, and I'm hoping sometime around the breakfast tacos with nothing more than being the breakfast tacos, that we may have another internet moment for the healthcare system. And let me just give you a few things that I think are really important. Some of these pre-existing, the pandemic, and some are after it, but these are things I want you to work on. We need Socio-behavioral approach is very important, right? We know that about vaccines. You can have a vaccine, but people don't take them, they're not useful. And distributed technologies to transform the sick care system into a health promoting system. We can't just get people when their diabetes is out of control, when their blood pressure is 200 and they have end-stage renal disease. We have to get them early. We have to have technologies to prevent or treat our most costly medical challenges. End-stage renal disease, I have a whole thing about that. Falls. There's a lot of technological and distributed technologies that can help prevent falls among the elderly. Pain, mental illness. Look, I'm a big proponent of psychedelics. I don't know if you guys are into psychedelics for treatment of depression and suicidality, but this is a major new field that's not, the LSD of the 1960s. This is real neuroregenerative, putting out dendrites and axons to reprogram the system to help you deal with things. We need to have advanced care out of hospital settings, including rural environments. This is telemedicine. This is testing. This is the bathroom that when you sit on the toilet measures your body weight and body water, so we know if your congestive heart failure is getting worse. It's your phone to see whether you're not moving your phone as fast or not walking around. Maybe you're depressed. Maybe you're becoming demented. All these kinds of things can be important. Big data, social networks, and digital platforms. We got pretty far with Facebook early on. But I do one search about something, and for the next 20 days, I have advertisements about everything. And I know this is getting into one of those areas, but if we're going to deal with teenage suicide, we're going to have to, in a respectful, privacy way, understand when a 13-year-old young girl is about to commit suicide, and I think those data are probably there. We need to have the guts, the policy framework, the ethics, to try to work on that. And I'm not talking about invading anyone's privacy, but when suicides are going up 50% a year in their 13 and 14-year-olds, we have to use the power of the internet and social media to do something more than self-hurting and underwear, right? If we could prevent those deaths, we need to do that. I am passionate that we need to end infectious disease epidemics that within our technical control. I'm not a big HIV advocate or anything, but I proposed this and got it to the president because it was obvious. We can end HIV, we can end hepatitis C, we have cures for these. We don't have a cure for HIV, but it's essentially a chronic disease. If you're on medications, you have a normal life expectancy, right? So it really is turned into a chronic disease that's not transmittable. And HPV, hepatitis, human HPV for cervical cancer or oral cancer. There's no reason why we can't get rid of 90% of that. I would declare war on maternal and infant mortality. A war on cancer is not tractable. We don't know how to cure cancer. We can stop maternal and infant mortality. This is a matter of reaching people who are underserved, having testing in their homes, having constant contact. We can do that. Make gene therapy affordable. Okay? Gene therapy is going to be great. Sickle cell disease, one of my big passions. I've done a lot of service on that. Really good. We're going to have a cure for sickle cell disease. It's going to cost $3 billion a shot. Okay, how many people who can't even get a $20 drug for their sickle cells are going to be able to afford $3 million? There are ways to make it affordable, right? We know Moore's law for semiconductors. Let's have a Moore's law for gene therapy. We don't have any idea about neurodegeneration. Everything we've done has failed. We know some things that are important, like physical activity, avoid obesity, avoid inflammatory things. But and this could be from your AI people, this could be from anyone out there to understand a new paradigm. And finally, global health security. This pre-existed the pandemic. We really need a ubiquitous global capacity for early warning detection, diagnosis, mitigation, and that's a whole other topic. I will say that we have an opportunity from the government, ARPA-H. Many have not heard of this, I was surprised. It is the DARPA for the health community. It's modeled after DARPA. It's going to be high risk, high reward. It was actually funded in the omnibus plan for $1 billion for its first year. So when you think of the internet, you think of stealth, and you think of GPS, and you think all the things that DARPA did. And this is Biden's #1 priority. It was not a priority in our administration, but it rose to the priority. It's going to exist. And by the way, it may not be in DC. One of the 3 cities, aside from DC, they're looking at is Austin. To locate ARPA-H as a center of innovation is very important. So I'll end with this. Here in the Capitol Factory House. I just want to ask where you stand. We have some challenges. Challenges made worse because of COVID, no question. Challenges are made worse because of our pre-existing condition, which we've lived with for decades, if not hundreds of years. So I'd like to end with this. And I started using this slide when it was at dark, and if you've seen it before, I apologize because you're going to see it again. New York Times on October 9, 1903. This is a quote from the New York Times. The flying machine which will really fly might be evolved by a combined and continuous efforts of mathematicians and mechanicians in from 1 million to 10 million years. On the same day, we started assembly. And that's sort of the way I feel. And I hope this place is a place in the factory that we can start assembly on some of these profound health problems, profound health challenges that we have lived with for decades, made worse by COVID. But because of innovation and the way we are in the future of public-private partnerships, I think we can change the future. I really thank you for having me, and I think we have 10 minutes for questions. Thank you.
I don't know about you, but the first 3-letter word I can think of is wow. Are we all on the same page? Yes. It's such passion. It's such passion. Thank you so much. We're very lucky to have your perspective. Would love to open this up for some questions. Please raise your hand. I'll run over. Okay.
Yes. In one of the first charts, there was that scatter plot between life expectancy and
Yes.
cost. And I have the feeling that through all the presentation, you have directly spoken about increasing the health of the population, but just indirectly talking about reducing the cost, because there are two strategies, no? Increase the health to put it at the part of our cost, or just put the cost at the part of our health. So, since all the talk has been in the direction of improving the health, do you foresee that maybe a disruption in the healthcare system will come in the cost side, not in increasing the health, but drastically reducing the cost?
If I understand that correctly, I hope not, right? I hope that we put health as a priority and not cost as a priority. And what I want to say is we can have both, but we have to approach it in a very different way, right? We have to approach it by not being this sick care system, but a health promoting system that democratizing and distributing health care. Yes, we could ratchet down the cost, so we'll have a low-cost system with poor health. You know, that's not our goal, and I don't think that's really anyone's goal. It's certainly not productive for the country. It's not productive for plans. It's not productive for anything else. It's a possibility. It's sort of an Orwellian bad possibility, but we have to guard against that. I think we can achieve both, and you know, that's through some of the mechanisms that I talked about today.
Oh, go right ahead, and then I'll.
Yes. Or,
Oh, yeah. Forgive me.
Thank you. I think that presentation was equal parts inspiring and infuriating for me, and I'm really.
thank you. It should be.
Yeah. This may be less of a question, more just a request for a comment or response, but I was looking at the charts and we're talking about things like obesity and rates of depression and maternal stress and drug use, and all of those things I think root back to mental health. But I didn't necessarily see mental health being placed at the forefront. And I'm curious what your response is, recognizing that I think a lot of our chronic health challenges have to do a lot with our inability to cope with some of the challenging emotions that we experience. And so I guess that's my request for a response is really what I'm asking.
You're exactly right, and I will put that on a spectrum, right? And the serious mental illness, SMI, in this country is horribly underinvested in. It's not early treatment. There's no parity with the, quote, physical side of the equation. 100% agree with you on that. 100% agree with you. And this is very important to just about everything. You said obvious things like depression and suicidality, but also substance use disorder. Now look, we need things like like cognitive behavioral therapy doesn't necessarily need to be psychiatrist, but the number one thing you do, if you're on opioids, you need MET, right? If you don't have MET, you can talk about it all the time, but you're going to fail 95% of the time. And on the other end of the spectrum, all of these, every one of these behavioral / social determinants behavioral need some kind of, cognitive behavioral therapy, supportive therapy, coaching therapy, all of these kinds of things. So there's a spectrum from, first psychotic episode in college that we are missing, and that's why people are on the street when they're 50, because we don't get them during that first psychotic episode, to putting people in the criminal justice system who really need to be in psychiatric facilities. And I do believe we need more, we need to commit people more easily. They can't just be in imminent harm within 24 hours if they're a harm to each other. We have to get them into therapy early. Touchy areas, all the way to just everything we talk about is not necessarily medical, but it needs that emotional support, whether it's CBT, coaching. And again, I'm very hopeful that a lot of this is telemedicine. There was a survey that 80% of people, I didn't put it on this because of limited time, would accept telepsychiatry or teletherapy as their primary, and that lowers the barrier to them. And it's very, very effective. So it's a very excellent point, and I'm glad you emphasized that.
Thank you. And one more.
Hi, Dr. Jarman. Thanks for your speech and for your passion for limiting healthcare disparities. I'm a technology entrepreneur working in clinical trials, and so I want to ask you more about Operation Warp Speed and the initiative towards finding eligible patient candidates from demographic representative backgrounds. I read an article in the Wall Street Journal delineating the difficulties these pharmaceutical companies have in quickly finding eligible candidates, especially from broad racial and ethnic backgrounds. So I was wondering if you had an inside perspective on the difficulties they encountered that delayed the clinical trial process ultimately.
Very good question. So it was very, very difficult to enroll, particularly African Americans, in vaccine trials. And we anticipated this was going to be super important because we wanted to be able to tell every racial and ethnic group that it was safe and effective in that group. It was brute force from Jerome Mattis. The Surgeon General. I mean, literally brute force. He went to every church community, he went to every company, he beat on them, and I mean beat on them to increase the enrollment. But it was brute force, and I give Francis Collins some kudos for that too, to increase African American enrollment. But it really was church group by church group, African American fraternities and sororities. They are really powerhouses. They are amazing in what they do, and that was brute force, and we have to do it different. What I talked about for Data Robot, they're a group I didn't know very well. They're about 500, 600 people. They primarily work with the Intel community. But what we found in the trials is we were always doing what we should have done 2 weeks beforehand, the companies were, going to areas that had outbreaks, but the outbreaks were already gone. So Data Robot, through all their analytics, all the things they do, were able to point the NIH to specific areas and specific groups where the outbreak was going to be, in a few weeks. And that's sort of how the trials got expedited. So brute force on the African American side, very high data analytics on that side to get enrollment, and then sort of an integrated public-private partnership. We need somebody to study that and to sort of make that part of our policy framework, because we do a lot of that with things like cancer too, right? In other diseases, not just during this kind of outbreak. Go ahead, Nick.
So related to that, you see technology platforms, like social media platforms, as having a crucial role in terms of directly engaging with prospective trial participants or connecting them directly to clinical research?
I absolutely do. For clinical research and every other thing. When I got named testing czar and got thrown into the Rose Garden on March 13th, said that we needed a national platform and an app within tomorrow. The COO and the chief health officer of Apple called me on Saturday night, just called me and said, you give us the algorithm, we'll do it. Within 10 days, they had an app up with millions that were directing people. Do you need to get tested? Do you not need to get tested? If you are positive, where do you go? Which was really amazing, right? And it was really critical to our early engagement with testing. I'm not familiar if that went on with the vaccine trials, but obviously people communicate through social media, That's the way information is done. The only thing I would say is, we have to be careful. I believe in patient autonomy, right? I don't believe in coercing patients, right? So there's a fine line between marketing something to them and getting them to do what you want versus getting them the information for them to make their own decision for themselves and their family. And that's just my perspective as an ICU doctor, right? Is that there are a lot of good choices, there are a lot of bad choices. My job is not to be, Marcus Welby in 1950 telling people what to do. And I don't think it's social media's job to do that. It's social media's job to give people the information and to empower them to make the best decision they have. And I think that's the line we see.
Thanks for your response.
Excellent. I think we could go on all day.
Thank you.
Thank you very much. Oh my gosh, what a great way to start. I hope you enjoyed how we kicked it off. Let's take a quick break. By the way, restrooms, if you do not know, are on the other side of the elevators. Grab some coffee. We still have tacos, water. We're going to change out for our next session that will be sponsored by, in partnership with AWS. Thank you. Panel is Beyond Care, Accelerating Startups for a Healthier World. Again, presented by AWS, and it will be fantastic because we're also here during this panel from Rock Health, Kids X, Dr. Gupta, and quite a few folks, and Martina with AWS as well. So please give them a warm welcome to the stage. Come on up.
Thank you so much, Dr. Gerard. That was a fantastic talk. My name is Martina Scarin. I lead the business development team at AWS in venture and startups in public health. So it's truly inspiring. And today we have Dr. Vin Gupta. He's our Chief Medical Officer of the COVID Relief Program at Amazon. So I let him introduce himself. He has a great background with a lot of experiences.
Thank you, and it was great to listen to the Secretary's comments just now. And thank you all for having me. I'm a pulmonary critical care doc by training. And at Amazon for the last 2.5 years have learned on the fly on how us as a company enterprise-wide, both on the consumer side, AWS and our devices initiative, how we have tried to respond to the pandemic worldwide and have helped to lead at least the clinical medical aspects of that. So it's been really interesting just to have an evening shift at the bedside caring for a patient with COVID-19 and then be able to work for a company like Amazon that's trying to really engineer problems for its workforce when it comes to how do we keep a workforce safe, 1.5 million individuals worldwide, both blue collar and white collar, and then how do we actually translate those solutions to communities in which we're in.
Sounds great. We heard a little bit about Alexa Health. Can you tell us a little bit more about all the Amazon innovations that were occurring during COVID?
You know, I will say that I've noticed this as a clinician that spent, prior to my time at Amazon, had worked on the O2 monitor here in the Apple 6 series watch here. Open to feedback, what you like, what you don't like. I will say that after you go for a run, you can't get an O2 reading. That's a big problem. But I will say that Amazon historically has not considered itself a public health company. And yet, as a clinician, seeing how this company has operated for the last 2.5 years, I think it is. Either through public-private partnerships, leveraging middle last mile capability. You know, the Secretary talked a lot about what the at-home healthcare environment is going to look like, what it's already looking like, how it's being transformed by this pandemic, how the policy landscape has really changed over the last 2.5 years to make us, to allow our patients, to allow all of us to do more things in the home environment. 2.5 years ago, we couldn't test ourselves for COVID in the home environment. It wasn't allowed from a regulatory standpoint. And because of the policy changes that were made in 2020, now accelerated in 2021, we can do those things. And so we were delivering tests that we've developed internally, that others developed to public school districts across the country. We stood up something called the Seattle Coronavirus Assessment Network. Back in March of 2020, you go to an app or a website, you say you have certain symptoms, and we deliver through Prime Delivery a same-day test. And so over time, and I'm not saying Amazon didn't struggle, it didn't learn from its mistakes, but over time, this company has really embraced its role as a public health company through middle last mile logistics, getting people stuff when they want it at their home. I know we're going to talk about that in a little bit in more detail. The new innovation with Teladoc. You can ask Alexa that you want to speak to a provider, and you'll immediately get connected to a Teladoc provider to troubleshoot, at least through audio, some basic problems, and then you take the next step if needed. So I think the company is trying to meet the moment of giving patients healthcare where they want it, which is at home. And we have a variety of initiatives underway to do just that.
Yeah, at AWS, we actually launched our first Accelerator last year, and we have some of our startups here today from that Accelerator. We had Pieces, which was a social determinants of health company. We have BeWell, who's speaking later today. We have Vina, who leads a virtual rehab group for post-stroke patients. So we're excited to talk about some of those innovations on the AWS side as well. And tell me a little bit more about the at-home testing. I think we heard how some of these disparities were really amplified during COVID. Can you share a little bit more about some of those innovations?
So we have a variety of efforts underway internally at the company to take the next step. And so I say this as a pulmonologist, but there is more than just COVID-19 that can cause sniffles, that can cause shortness of breath, or lands you in the hospital on a ventilator or an ICU. There's over 20 endemic respiratory viruses that exist all around us all the time. There's vastly more than that, but 20 that we routinely sense or test for if you get a bronchoscopy and insert a camera down your lungs and see what you may or may not be positive for if you come into the hospital. There's a lot out there, and I think COVID-19 is going to go down, hopefully, that trajectory of being something we test for when we need to test for it, when it's causing severe illness, but something that's not going to cause worldwide disruption. We are trying to figure out what are those tests that can be embedded in the at-home environment. A multiplex, for example, a multiplex respiratory viral panel. So it doesn't only test for COVID, but it tests for, say, flu. Other common respiratory illnesses that could land you in the hospital, because symptoms are non-specific from COVID, and treatments vary. Yes, if you test at home, for example, you test at home for COVID-19 and you test positive, and let's say you have an underlying condition, or let's say it's grandma, grandpa who test positive. We want to get you treatment in the at-home environment as quickly as possible. So it's something, Martina, that we're working on is how do we virtualize the experience, the care experience for if you test positive for one of these diseases, whether it's COVID or flu, how can we get you same-day treatment at home? So you don't have to go into a pharmacy. You don't have to go into a brick-and-mortar clinic. Preston Biden just announced the Test for Treat initiative, but that still requires some friction. You still have to go into an in-person pharmacy. And I know grandma, grandpa, or somebody who's high risk who might be positive doesn't necessarily want to have that care experience when they're feeling ill. They want convenience. So we're trying to deliver on that. How do you pair in a virtual environment same-day testing with same-day treatment? It's imperfect now, but that's our North Star, not just for COVID, not just for flu, not just for respiratory viruses, but for a variety of different ailments as well. Narrowing that window between diagnosis and treatment. I think that's something Amazon can do.
That's really great. As we think about digital transformation and some of these amplifications in healthcare disparities in our communities, I've been really thinking about what we do in public health. How do we continue to help policymakers, payers, pay for different solutions or work with our innovators on different business models? Do you have any advice for this space as we have a lot of transformers in the room? What would you say, and how do they best work with policymakers and other payers to get their solutions paid for?
One thing that we're wrestling with right now is who will pay for this service. And I'd like to think that some of the headway that was made with how do we pay for, say, the Apple Watch. My time at Apple, as an example, private Medicare Advantage programs that were innovative. I look at Devoted Health. They said, you know what, we don't have years of clinical outcomes data showing that the Apple Watch, which is not a medical grade Class 2C device approved by the FDA, it's a health and wellness device. There's several like it across the country, made by other tech companies, not named Apple. And yet, they are making a bet that people will want to track their step count, now maybe their oxygen trending over time, even though it's spot checks every hour, their heart rate monitor, and that's going to improve health outcomes. And so they're willing to subsidize it. Devoted Health, at least, private Medicare Advantage programs. Others out there are willing to take bets that I think historically, at least pre-pandemic, we didn't see these types of bets in the payer space. You needed years and years of clinical outcomes data to show that something had an ROI, and then it would get paid for. And so I'd like to see virtual test and treat, whether it's Amazon-led, there's a lot of healthy competition out there, that service would be paid for as a covered benefit by an employer or by an Aetna, CVS, for example, any third-party payer, that they would see the value in keeping high-risk enrollees at home for that care experience. Early tests to treat in the virtual space. There's no reason why we can't virtualize it. All the great innovation that was laid, all that groundwork that the Secretary and the administration laid out, that foundation to let rapid testing at home really take off in the last 12 to 16 months. Well, we need a way to pair that rapid testing and that innovation at home, that diagnostic capability at home, with the back end, which is treatment. And there is same-day delivery of treatment for certain medications, depending on the state that you live in. You can actually say in 24 states right now across the country, you can asynchronously, if you are eligible, you can asynchronously engage with a clinician on the back end. You can say, you know what, I'm high risk, I just tested positive. Under the terms of the emergency use authorization for Paxlovid, the Pfizer oral antiviral pill, you don't actually have to show proof of a positive test. You can say, I am positive, I am high risk, you can self-attest, present your medications. If there are drug-drug interactions or any concerning allergies, you can assess for eligibility, and a clinician on the back end does not actually have to physically see you in these 24 states to say, you know what, we're going to approve Paxlovid for this individual, we're going to get it to this individual same day. Within less than 10 minutes, you can have that care experience. It's not built yet, but we're trying to build it here. I know others are trying to build it. In the other 26 states, you have to have a synchronous care visit. You actually have to see somebody in the virtual space or in person. And so I would argue that for all 50 states, we should have a similar approach here. Let's make it easy. I think health literacy is at a point now that it has never been across the country. People are aware of their own risk. They understand concepts of health stratification. They can stratify their own health risk to a certain degree, and likely much better than they could 2 years ago. We should take advantage of this movement, that people are more aware of what they're eligible for. I can't tell you how many patients have come to me who are high risk who ask for Evusheld, the IV monoclonal antibody that helps support as a prophylactic one's protection if you don't mount an adequate response to the vaccine. These are people who are saying, you know what, doc, I listened to something that was said on TV. I'm coming to you because I want this medication. Literacy is really high, and I think that's enabling us to do more in the virtual space.
You know, one of the things we've seen too is a lot of misinformation, mistrust, especially after COVID, especially as the outcomes have gotten worse. Is there any advice you have there on how to rebuild that trust or how technology can play a role?
You know, I'll say it, at Amazon, when we've tried to communicate with our workforce in warehouses across the country, why should you get the vaccine? I mean, this is 6 to 12 months ago. When we first started these efforts, we leaned in on some of the tactics that, in my view, again, as a long doc focused on tobacco prior to the pandemic, that were so successful at reducing the burden of smoking across the country, across the world. Smoking is still the leading cause of death for humanity worldwide, but the number of absolute people dying, or relative percentage of people dying from smoking, has dramatically decreased over the last 50 years. Still a huge problem. But what do we use? We use clarity in messaging. We use visuals. I post frequently on social media. We use this in our internal communication channels. What do lungs look like with COVID? What do they not look like with COVID? These types of clear messages in the digital space gained a lot of traction, and I think they really trained the mind on why do you get vaccinated. Now we're talking, the Pfizer CEO is talking about a 4th shot. We're talking about these new variants. There are inevitably going to be new variants. How we expectation set through clear messaging, visuals, works so well for the anti-smoking campaign. I think we can co-opt that. But misinformation, the ways in which Amazon can democratize that information, spread it, you know, we can play a really vital role.
Well, thank you for all of this. I'd love to invite some of our other speakers to join us for the next part of the conversation. Great. So right now we have Dan and Lee from Kids X and Children's Hospital of LA. We have Katie Dresser from Rock Health, Veena Samreddy from Virtual Rehab, and then Vin Gupta. Thank you, guys. I'd like to kick it off with Katie, but I'll let it. You know, Katie, during this pandemic, we saw record levels of investments in healthcare and digital health. I mean, it's crazy how much money is going to this space. Considering where you all sit at Rock Health, and please do share a little bit about your role and Rock Health as an organization, are there any general trends that you'd like to share, or sort of the big picture challenges and the promise of digital health in this age?
Start with the small. Oh, I gotta do my mic. Just gonna start with a small question. Thanks, Martina. It's, you know, not broad or anything. No, but for real, Vin, I really appreciated your words, and I'm really grateful to be here with all of you. I actually think in this room, what is represented is the ecosystem of digital health. We've got enterprise entrepreneurs, VCs, I know many of you, and many others. I know there are providers in the room. Most of us are patients or caregivers, and so that's a lot of what we do at Rock Health is work with the entire ecosystem that we define as the intersection of tech and health, digital health, to figure out what is the promise and the potential and how can we collaborate and work together. I believe the title of this day is something around partnerships, and I think at this moment, like, it is going to take all of us to figure out how we move forward and not leave people behind, and that is a lot of our work. I think, you know, I'm reminded this day 2 years ago, the WHO declared COVID-19 a pandemic, and it's just helpful to remember because we started 10 years ago at Rock Health. We've been doing this, we've been working with innovators across the sector for 10 years. What has happened in the last 2 years is, as you hear words like unprecedented, eye-popping, and that is all true, and what more is there to do? So just last year alone, $30 billion of VC funding went into digital health. The year before, we thought that number was like astounding, and this 30 billion was more than double that. Those trends are continuing. We're seeing some different changes. What's come from that is, you know, more VCs are getting into this space than ever before. New entrants are coming into health, like Amazon and AWS, but you mentioned Apple, Best Buy, others. Folks who have long been in this space, we've worked closely with CVS and many others, they're doubling down on their digital health innovation, and we're seeing more and more founders, not just found companies, but massively scale and accelerate their growth. Some are now exiting. We're having a lot of different kinds of exits at this moment. So what do we do with this momentum? I would end with what's not happening and where I actually think there's the biggest opportunity. When you look at that $30 billion, who's that going to? 14% of that funding flowed to women, only 14%. When you look at who consumes health, and get this, almost half the founders and leaders in this space are women. So like, that's a problem. But here's where there's potential. If you look at where VC funding normally flows, only 2% goes to women. Like, this space is outpacing other industries, and there's so much we can do here so that we can make health equity advances, so that we can fund Black and brown founders who get 1% of VC funding overall in the whole VC space. In digital health, it's more than that. Like, we have a responsibility to double down on this and actually not just like find these leaders and fund them and found them, but then what are we going to do with that money, and how do we direct innovation so that they actually make public health gains, so we actually don't leave communities behind? We can do that, but we have to actually be paying attention to it. We have to lead with equity-minded principles. We have to look at who we are funding and funding for which communities. And I see endless possibility with that, and I think that's how we're going to future-proof digital health. That's our job, and that's what, at rockhealth.org, that is what we are deeply, deeply committed to doing. So, yeah.
I love that commitment. So I mentioned we launched our first accelerator last year, and as I think about public health and I see some of the challenges that we're facing, I do really believe that the founders have to come from these communities, and that's how we can help solve the problem. In our last accelerator, we actually have two of our female founders here, but we were very proud of the fact that we had 70% of our founders be female, and 92% had some aspect of diversity. So we also had the great fortune of working with Dana Lee here from KidsX, and I'd love to hear about what KidsX is doing, what Children's Hospital of LA is doing around accelerating startups and growth.
Yeah, that sounds great. So KidsX, we're one of the world's leading digital health ecosystems in the world. What we've been doing is actually building innovation challenges, accelerator programs, innovation programs that actually support companies and entrepreneurs that are interested in accelerating within the healthcare space, especially selling to hospitals. I'm talking to the room that already knows how slow it is to adopt within hospitals, so I don't have to go too deep into that. But what we actually do support is that we're able to actually take the startup step by step and understanding how they're able to scale within not only 1 or 2 or 3 hospitals, but we have that consortium of hospitals in our network that are all interested in mentoring, providing some type of data, or even like being a pilot test site that they're able to actually connect and move forward with. So we're that middleman that can nudge the hospitals and nudge the startups to actually accelerate that sales cycle. And typically, you'll hear, this is actually a stat that I heard from Rock Health, is that it takes about 12 to 18 months for a startup from that intro meeting all the way to going live at the hospital, and that's a long time. So what we've been able to do is actually decrease that sales cycle and make it about 6 to 8 months, which still feels a little long, I think, if you look at other industries. However, we want to make sure that we can accelerate the companies that go through our program, go through our corporate partners programs, and be able to actually support innovation in the space.
Great, and I'll share a little bit more about the Accelerator. So we accept 10 companies. We had about 430 applicants last year for the first one. We accept companies that have validated solutions, they have some paying customers, they've raised some revenue, and we try to create a network similar to what KidsX does, of hospital partners, corporate partners, access to capital, everything that startups need to grow. And with that, I want to turn it over to Vina to share a little bit about your company and your experience within the Accelerator.
Thank you for having me here, and I love being with my favorite people that I work for. Okay. It is on. What about now? Is this better? Okay. Is this better?
Yes.
Okay,
Yes.
awesome. Well, thank you for having me here, and the Amazon accelerators have been one of the best accelerators we've been through. To give a little bit of introduction about my company, we develop virtual reality applications for physical therapy and occupational therapy. We work with a lot of patients who have stroke, brain injuries, spinal cord injuries, and help them get back function so that they can have normal everyday lives, and also provide the data analytics that they would need for tracking their progress. So being part of the Amazon Accelerator, we got one technical advice plus business advice, which people forget, especially with me. I come from the product side and technical side. I came with the notion that you build a product, people will come. That doesn't usually happen. I learned it the hard way. And I think Amazon and AWS know that from the beginning, and they were able to help us with security, regulatory processes that we would need as a startup, work with how do we scale once we get to a point of cloud optimization. You have all the services that you would need, and then work with the business side. We were able to work with hospital leaders like CIOs, chief digital officers, to understand what are they looking for in a startup, how do we approach them, who are the right people, and what is the process of getting to a system-wide adoption. Something that we've not been able to do on our own without having access to leaders like that. So, and then being able to work with Martina and Adam and Katie and everybody else gave me the confidence, being a woman founder and a woman of color, that I can do this. You just told us that only about 2% VC funding goes to women. There's another stat that's only 0.002% of VC funding goes to women of color. So at the same time, I was also raising my first seed round, and statistically, I was not supposed to be able to raise this round. But being part of them, just getting into the AWS Accelerator, talking to people from Rock Health, gave me that confidence that if I was able to get in with 10 startups out of 430, I should be able to close this round, and we were to finish that at the end of January. So thank you for giving me that confidence and just being this overall accelerator that just brought us to that next level.
And I just want to say those numbers are abysmal. I feel so disappointed because they went down during COVID. When we needed solutions that were coming from the community, public health solutions, and we were raising more money than ever, women numbers decreased. So with that, outside of those opportunities and challenges, what are some others that you're seeing? And I'll throw this out to the group and whoever wants to join. What are some of the opportunities and challenges that you're seeing right now in the innovation space?
Well, I'll just jump in. I just in listening to everybody talk, it takes us back to the conversation we were having, the Secretary's comments earlier as well, that without this innovation, I don't think we'd be having debates on that we should be having on the policy side. So one of the big issues here that because of all of your hard work that we're having, just everybody in the room, We're having interesting conversations now about whether pharmacists should be prescribing more medications, whether more medications should have OTC indications. I'll go back to Paxlovid, the oral antiviral for COVID. Should a pharmacist be able to prescribe that? I would argue yes, that it's pretty protocolized what we should be doing, what we shouldn't, because we can deliver it in a digital health type of ecosystem more easily. You don't have to leave your home. That's one. Physician burnout or healthcare workforce burnout. Being able to actually continue all the great emergency policies that were put into place early in the pandemic on cross-state licensure, practice of medicine in the virtual space, making that permanent helps with burnout, helps Vina and your service reach more people, because rehab is a big problem. We don't have enough rehab providers across the country. So being able to practice in Seattle and provide care in Florida, I think that's going to be important for your long-term business model, in my opinion. But healthcare systems need that stability and policy. We're having these types of discussions because of innovation.
And to piggyback on that, I think since the pandemic, we've had more and more conversation about how to bring this to the home. And for us, we always start with, this is our assumption, let's validate it and understand if it actually works. So we're able to send one of our devices home to a patient who, here in Texas, when we had the freeze, he slipped on black ice and broke his knee, had his knee surgery, and just had a little bit of rehab, about 2 days, which is not enough, and was sent home. So for about 6 months, he was weight bearing 50% of all of his weight on one side, on the non-affected side, and had like less than 60 degrees of knee flexion, which is not enough for him to be able to walk around in his house on his own. So we were to go into his place, give one of our systems to him, and then he did a trial with us for about 2 months. In just 2 months, we were able to get him to 105 degrees in knee flexion, 100% weight bearing, and he was walking around his house in without an assistive device. So we were like, I'm not saying like, here, for us, we were like, this was a very easy, small intervention that we did. We only went to his home a couple of times, and he was able to do all of this on his own. It's either saying something about the healthcare system, about access of care. I know our product is amazing, but I don't think it was just that. It was just giving that access to care for him. We were to get him to a point that is much more independent than he would be. So with this case, take that and scale it up to everybody else who would need this, and with digital health, you can do that. You can bring down costs, make it more efficient, and give that education and continuum of care for people from acute care to post-acute care, and I think that's what a lot of us are working on too.
What we've been able to do in our position too is actually talk to the hospitals that are in need of innovation in particular spaces. And so we are similar to AWS, customer obsessed, and we talk to our hospitals and talk to them about what they're willing to put money in terms of innovation. And the two main things that actually popped up was social determinants of health and mental health. And I think that both definitely has shed a lot of issues in light during the pandemic even more, and you can see that the disparity within certain communities has shown even more within just this past few years. And so I think that that's something that we want to move forward and think about as we look at future startups and solutions to target.
Yeah, and I think you raise a great point. What we realized actually in the pandemic was technology itself is a social determinant of health, and having access to broadband internet and expanding that access in order to provide care at home. Vin, I don't know if you want to add anything about the broadband expansion.
I will say that Amazon, what I can disclose here is that we're working hard to increase access to broadband in more communities, so that everything that we're talking about is not just accessible to people who have smartphones, that there are different mediums in which you can actually access some of these services. But I think we're having a candid conversation, being able to access Teladoc through Alexa, or being able to access virtual test to treat right now there's a critical barrier there, and that's socioeconomic. And that's the ability to have broadband access. So this is version 1 of what I hope is going to be a version 2 that's going to be more accessible to more people through different devices that don't cost $1,000, at least in the case of an Android or a smartphone. But so there are challenges here, but these are overcomable.
I would just add to, I feel like there's a public consciousness about what public health even is. I've talked with some of our partners, like, I have a public health degree. Just last year, my mom was like, oh, I get what you do. I'm like, 20 years later, but okay. There's a consciousness about the digital divide, or the role that broadband and internet and smartphones play in achieving health outcomes and goals. I think what's coming from that is all these folks want to innovate in this space, and like, how do we make the path to innovation so much smoother? This space is not for the faint of heart. There are far easier ways to innovate and far easier ways to make money. So what you find is a lot of people are coming into this with a pain point they're trying to solve, and I think entities like KidsX, the AWS Accelerator, to the extent that you make that path just a little bit easier, that counts for a lot. Because people, they run out of money, they feel defeated, and to the extent that, you were saying, like, help with the regulatory, help with it, that is no small thing, and we shouldn't expect every person that wants to innovate in this space to know all that. Like, no one knows all that, let's be clear. So together, though, I think there's a lot we can do to make that path smoother, so that more different folks can be innovating, and so that we get closer to some of these, public health goals or whatnot.
I just want to quickly add, just in hearing you speak, Katie, I think there's an assumption that a provider knows how to be a great provider virtually versus in brick and mortar. In brick and mortar, you put a stethoscope on somebody's chest, they think you're doing something, and it's even though as a lung doc, you have to do that, otherwise they're going to wonder what you're doing. In the virtual space, though, a lot of that doc, at least provider-patient relationship, the terms, the dynamic of that, totally different. And we don't have a parallel structure to train in nursing, in rehab schools, and schools of medicine. How do you actually be effective in that space? And so, what does good follow-up look like if you got asynchronous medications without any actual direct clinical interfacing with a provider? And so I think we have to, as there's innovation change on the delivery side, I think we have to educate in a different way as well.
Yeah, one of the things I feel actually optimistic about is more of the public health equity accelerators, Broad Health having a focus on health equity, and just the creativity of public health solutions we're seeing out there. I love the 10 startups in our cohort. I'm also seeing really interesting solutions like Live Chair, where folks partner with barbershops, because that's where trust in the community is, and then they wrap around primary care or other services. That's what I'm hoping we'll see moving forwards and in the future. So with that, I'd love to just go down the line and talk about your parting words and your challenge to the group.
I can start. So what we've been able to do, and especially since we're talking about the underserved communities and being able for them to adopt solutions as well, is that actually providing capacity building activities for them, along with empowering them in actually building these solutions. And so at KidsX, we've been able to do that by partnering with our local Department of Public Health and reaching out to the faith-based organizations, community-based organizations, nonprofits, and actually empowering them to become innovators and supporting them in actually being able to build out solutions. And we want to do that not only with just, people who are already entrepreneurs, but people who can be an entrepreneur, who can be an innovator. And so I think that there's an opportunity for that, and I want to be able to empower people to do that.
Awesome. I don't know that I have the wisest parting words, but I'll say two things. One, I just pay attention to the systems we're sitting in. We're sitting in systems that are hard on people. And what can we be doing to actually change those systems? And there's a lot, and a lot of folks like me, these folks are doing that. But remember, we're sitting in a system and we have the power to change these systems to work better for us and each other. And also fund these people. These startup entrepreneurs, yes, they need advice, sure. Fund them. Put money behind all kinds of new people. Just
Thank you for that. I think for me, for the startups in this space, always said, find your product market fit. And I think as a startup, it's all about, you start with assumptions, you think they're amazing and you know you're doing the right thing. But unless you talk to your customers and ask what they need, you won't really know. So we what AWS changed for me is just being able to talk to hospital leaders. I'm doing more and more of that. And I'm talking to CFOs, making them my advisors and mentors, so that when I can pitch to them and say, this is what I'll pitch to your hospital, is this something that you would be interested in? I can take that. And everybody is amazing about giving help, and they're really generous with their time. So rely on people like AWS and Rock Health to get you to that next phase, and always validate those assumptions as much as you can, so that, and then as Vin was saying, we are focusing more and more on education. It's not just giving somebody the product, it's about telling the patient how to use it, how the therapist can use it, and also how it fits into their continuum of care and their care system. That has made a big difference for us, and we're putting more and more effort into that. And I would tell that to all digital health startups too. Product market fit, education, and always obviously funding.
Thanks, Vina. Well, I was just going to, because of the hard work of Dana, Katie, and Vina, we can really reach that goal of 95% virtualizing primary care in the home in ways in which I think 24 months ago we weren't there from a policy standpoint or an innovation pipeline standpoint. I will say I feel like to truly capture on the potential of the moment, with health literacy very high, we really need payers in the same room as providers with all of you, so that we can identify what the hurdles are policy-wise. There are many, and the devil's in the details, and unlock them but to build awareness. Because a lot of times, I will say, you go down the street to a different pulmonology clinic or pediatric clinic, they don't know that some of these tools are available to them. And so awareness, trust in these services, getting them paid for, having that conversation together is going to be really important.
Great, well, it takes a village, and I have the great privilege of working with all of you every day. And so with that, I do want to open it up to the group if folks have any questions.
Oh, he tapped me on the shoulder first. I'll be right back.
Hey, first of all, thank you very much. Great discussion. And I wanted to build on something that Vin said earlier. And I'll start with the caveat that I'm a physician and CEO of a telehealth and digital health company. So I have that bias, or those biases. But I totally agree we shouldn't do what we've done in healthcare for years, which is wait for years and years of data to make a change or to start paying for something. On the other hand, the flip side of that is how do we prevent what I call digital snake oil, right? So when I do consulting, people come to me and say, oh my gosh, I have this great idea, and they really don't understand the gaps in healthcare, and so they have a great solution, but not for any problem that we currently have. And they say, well, can I sell it? I'm like, of course you can sell it. So whether you can sell it or not is actually irrelevant. It's whether it's going to have an effect or improve outcomes, right? And so I agree we shouldn't wait for 6 years worth of data to go ahead and make some changes. So I really applaud the disruptive innovation that's out there from industry. But will we get the healthcare right? Innovating is great, but without outcomes, and eventually we're going to have to be responsible, right? So I like the balance between bold and innovative. You can be bold and you can disrupt, but then on the other side, you have to be responsible on the flip side and figure out, does the data actually prove that we're improving outcomes? So how do we avoid digital snake oil is my question.
I guess I can start because I have seen other startups in the space just like you, and when I see like they're really not solving something, that's why we concentrated on the outcomes since the beginning. And we started with case studies, is this really working for our patients? And we were lucky to be started inside a clinic. So we had access to physical therapists, patients every day that gave us critical feedback on if something's working or not. And they were open with us just because we were around them. So we were able to get to that, let's get to that outcomes as soon as possible so that we know this is making a difference in people's life. And I think the outcomes is what we need to concentrate on. And then talking to the providers itself and your clients, saying, is this something that would work for you and how it would fit into your care continuum?
Yeah, and I can build on that. So within the Accelerator, we partner folks with a solutions architect who helps with technical validation. But one of our leadership principles is starting with the customer, working backwards. And so at the same time, we have mentors within the hospital systems, within the payers that help guide some of our startups. And I think it's that multi-stakeholder involvement and continued mentorship who, have Rock Health funding. So I think all of that helps, and it has to be looked at holistically.
Thank you for the great discussion here. My question is about the health literacy. You know, everybody agrees that we need it. That's one of the key factors how you can move the population to a healthier side. Does Amazon or any of your companies addressing that? Any programs around it?
I won't speak for Amazon, but there are a lot of entrepreneurs. And when I say entrepreneurs, I don't just mean like they founded a startup and they're building it, but they're entrepreneurs, you know, within big companies that are looking at exactly this question, because I think a lot of people see that as both something that we haven't gotten quite right, and there's a lot of opportunity to change. So I'm inspired, for instance, by Ashley Wisdom in Health Interview. I'm inspired by Lisa Fitzpatrick from Grapevine Health. I'm inspired by Ivali Sandino and what she's building, first with Radical Health and now Radical Relay, of a text-based way to navigate the system for patients to underinsured and Medicaid patients to text and ask, like, I have an appointment, but how do I get, you know, whatever that non-clinical question is that helps with navigation. To the extent these get adopted, and, you know, to the point about snake oil, I don't know that they get adopted as well if they're not actually working. So if they are working, and I might be Pollyanna, but hell, like, then my hope is like that actually those are the ones that succeed. I know that's not always how it works. Sometimes you just make money and that's how you succeed. But with these examples, these three women I just gave, Ashley Wisdom, Ivali Sandino, and Lisa Fitzpatrick, check out what they're building and doing. We should all be learning from that, you know, and absorbing some of, you know, partnering with them, absorbing, helping them scale, et cetera. They are proximate to communities. They are, you know, they are trained in health literacy. So, yeah.
The program.
Oh no, please.
Some of the program that we run is that we make sure that whoever the end user is, understanding what words, what language they speak, and making sure that that's what we are putting out, the startups that are working with those communities. So like ensuring that whether that be a module of them understanding, actually going out and doing that user research, being able to have those listening sessions, feedback sessions, to make sure, does this language that I have in this particular software app or whatever it is make sense to you because you'll be using it. We make sure that the language is inclusive because you have to make it inclusive for it to work and be successful.
No, and I'll just build and say that there is a tech task force that's been focused, all the big tech companies in the very first days of the pandemic on combating misinformation. And I feel like when it comes to how Silicon Valley has interfaced with good information, it's been simply to remove bad information and to change what the search query will show when you type in vaccine, Pfizer vaccine, whatever it may be, or Moderna. Not proactively putting out necessarily content about public health information. So there is an opportunity that is untapped. I completely +1 all the companies that Katie referenced. I think they're doing great proactive dissemination and evangelizing on good, easily accessible public health information. But if I have a moment of just reflection, I think the big tech companies could do more proactively, not just to address bad information. I will say to the comment on snake oil, real quick, what I found is, just to touch on both, I think, I know there's an effort underway in terms of what I can talk about to integrate many different efforts across our company so that it's not 5 different services all at once, you have to sign up 5 different apps, but it's integrated experience and there's a common sense portal of entry. You get a test, boom, positive, this, you go here. You don't, you get a negative test, you're good. And to me, it would seem that the snake oil offerings, of which I've seen many too, won't get integrated into a broader experience. And so I think just making sure that if there is an innovative startup, that it's easily accessible and it makes sense in the care journey through some sort of common sense portal of entry. For us, it's testing, or I need a refill on a prescription. So just the ways in which consumer behavior and health are going to target somebody to come to our website, they need something acutely. I feel like the snake oil stuff seems to not get integrated in a common sense way in those sort of broader stitched together packages of services in a virtual setting.
And I think there was one more question.
I don't need a microphone. I think we'll be okay.
Okay.
Thank you. Thank you for a great discussion. And I'm a physician as well, working
medical technology startup, spending most of my career in Silicon Valley, currently a medical advisor to Air Force Ventures. And digital health, particularly wearables, have really accelerated collection of a great deal of medical information. And there are many studies that are going on. I'm enrolled in a number of them, including Apple Health studies, and that's been terrific. And certainly over the last couple of years, with COVID particularly, all these devices have really accelerated collection of a great deal of data, public health data. My question is, these data are very valuable, obviously, to Apple, to Amazon, to all the companies in the space. How are we thinking about silos of those data, which are really health data, from marketing purposes and monetization? And I assume that Apple clinical folks probably have to face these questions when they're talking to IRBs, right? And Amazon obviously purchased PillPack, so there's a lot of integration between medical information and data that can be used for other purposes. So please comment on that.
I'll promote one of our other startups in the cohort in the Accelerator, One Record, another wonderful female founder. They pull the data from all the various health systems that have it and have the patient own the data. Use APIs to do that. You should definitely check them out. So there's just different ways to, I think, approach that problem and not have folks own the data, not have hospitals own it, not have Amazon own it, but have the patient own their own data.
I guess I'll take a first crack at it, but I defer as well if anybody's jumping on this. I will say this is me as a clinician, not representing Amazon's point of view here, but as a clinician, I think the way we do informed consent has to change. Right now you sign a paper doc and you can share my medical information as needed, but patient confidentiality and privacy and what we're willing to share or how we leverage that information from a watch or from any other remote monitoring device, I think to your point, there's a lot of potential there, but we're bound by regulations and by public perception to not really leverage that for marketing purposes. This could be good for you, maybe not this. I think with boundaries in place, we should allow people to make informed decisions about what they do and do not want to share. We just don't do that. We do not have a way to modernize informed consent and allow people to engage in that process should they want to. And I think that needs to change. And there will be a reckoning before long, I suspect.
On that note, thank you very much to our panelists. Please approach us afterwards. We'll be around. But thank you.
Fantastic panel. Really appreciated your conversation, especially AWS with startups and accelerating. I thought you were going to say something. All right, so more to come after lunch. Take a break. And we will meet back here at 1:15 for a presentation with our partners from Blue Cross Blue Shield of Texas, C1 Innovation Lab, as well as McKesson. We'll see you in 1:15.
check, check, check.
What up, what up, what up?
No need to stop chatting. I love it. Just wanted to let you know this is your 15-minute warning. 1:15, we'll gather back and get started.
it goes green, then it becomes a hot mic. It goes green, becomes a hot mic.
All right, good afternoon, everyone. Hopefully everyone is returning from some great conversation and dialogue over lunch. We are going to get started here, so if you could make your way to your seats, we will begin shortly. All right. Well, like I said, good afternoon, everyone. This is an amazing day so far. Great energy, great audience. My name is Summer Wright Collins. I am with Blue Cross Blue Shield and the C1 Innovation Lab team. We are excited to host this afternoon panel in conjunction with McKesson. And so, without further ado, I'd like to introduce our two speakers who will be starting our panel session. We have Kevin Cassidy, our Chief Growth Officer from Blue Cross Blue Shield of Texas. Yes, indeed. And we have Jennifer Danielson from Collective Health, the Chief Growth Officer, who will be a little bit about the partnership with our two organizations. So Kevin and Jennifer, please make your way and we will begin.
Thank you, Summer.
Hi, everybody. It's nice to be here with you today.
Good afternoon, everybody. Summer, thanks for the introduction. I think we're going to start by way of intro in terms of who we are and what we do at our respective firms. Do you want to start, Jennifer?
Sure. My name's Jennifer Danielson, and I'm the Chief Growth Officer for a company called Collective Health. We are a company that's based in the Bay Area that is focused on helping empower individuals to experience healthcare much differently and in better ways than they do today. For my own background, I've been in healthcare for 24 years, and a lot of it with companies that are familiar to Kevin and the Blue Cross Blue Shield family. So healthcare's in my blood, and this is very much a continuation of a journey for me.
Thanks. Good afternoon, everybody. My name is Kevin Cassidy, and I work for a company called Healthcare Service Corporation, but what that really means is we own and operate 5 Blue Cross and Blue Shield companies, including Blue Cross Blue Shield of Texas. So I'll be talking about our relationship, which is Blue Cross Blue Shield of Texas, and our innovation lab, which happens to be in Dallas. We call it the C1 Innovation Lab. I'm going to give a little bit of context about our company because I think that will help the conversation as you hear about how we, sort of a large, old insurance company, work with startups when it's sort of the right approach. So I have been with the company for 29 years. This is the part where someone in the audience says, "No way, he looks too young." Didn't happen. So 29 years, coming up on 30 this year. And to put it in perspective, we serve 18 million members. We're a $100 billion top-line company. And from a GAAP perspective, we're a $50 billion company in terms of actual insurance products. And we've been around a little more than 90 years. So I think the conversation today is going to center a little bit around just sort of healthcare, but also how a 90-year-old company works with success.
Yeah.
Sound good?
That sounds great.
So let me, if I were in your shoes, I might be asking myself, how does a large company that Kevin just described in terms of the long tenure we've been around and sort of the size of us, how do we think about working with sort of startups? First of all, we love startups. We love the startup community, and we have really good self-awareness that there are a lot of things that we cannot do inside that large company that I described. But when I talk to people, I say from our perspective, when I hear someone says, "Hey, I'm gonna change the way healthcare is delivered," that's way too wide of a net for me. I have to say, get a lot more specific for me. So we represent largely commercial customers. Those are generally, there's an employer behind the scenes that's buying health insurance generally, not always. And so one of my commitments to the employers is I say every day I come to work, I'm going to see how I can improve healthcare quality, improve healthcare cost, and improve the patient experience. So when I talk to startups, if they can check one of those 3 boxes, I say let's talk further. If they can check 2 or 3 of those boxes, I say that's a home run, and then that's how we ended up with a deep relationship with Collective Health.
Yeah, that's exactly right. And as a startup that's definitely not new on the block and has been around for a little bit, we've got a pretty clear vision about how to actually step into that space and do exactly what Kevin's talking about, where you actually can do things and engage with people in a way that helps them engage with healthcare in a different way, get a better and a different result from their own healthcare experience, which is definitely core to the founding of our own company, and ultimately do all of those things that Kevin talked about: lower cost, improve quality, and improve the experience across the board.
So one of the things we did when we sort of did a nationwide search for a company that we wanted to have a relationship with that had developed what I'll call claim processing technology, customer service technology, and care navigation technology. There are a lot of companies out there that are, most of our technology in that space has been around for a while. Don't tell anybody this, but we still have some mainframe computers programmed in COBOL. But so we had to look at sort of modern day technology with that in mind. And what we found is that there are a lot of companies out there that could have provided solutions, but we didn't find any that had not only the solutions, but this is really important, but we also had a culture match. our culture match really centers around the member who is carrying that Blue Cross and Blue Shield card, and what is their experience going to be when they access healthcare.
Yeah, changing that member experience is definitely at the core of the DNA for collective health. Collective health exists because of an experience that I think so many of us are familiar with in healthcare, where one of our founders had an experience in healthcare where he didn't know how to access information, he didn't know how to navigate, he didn't know how to get questions answered, and there was really sort of a dearth of resources available to him to be able to help him through that. So collective health, a number of years ago, started down that pathway with that North Star vision always of keeping that member experience and that member engagement at the core of everything that we do. I will say, as a startup in healthcare, healthcare is big, it's messy, it's complex. Like Kevin said, there are 1,000 different ways that you can connect into the system, and you've got to understand where you do fit. And technology is a great accelerator for doing a lot of that. But when technology, you can leverage all the technology, all the data in the world. But when you miss on that human component of healthcare, when you miss on how to actually get people to talk to you and to do things that can remarkably improve their own healthcare experience, then you're missing the opportunity to really achieve that real change.
Agree. Together, I find that we have much more success when there's a clear division of labor. And it's not always clear, but I'll give you a couple examples. So as we work with Collective Health, one of the things that they said early to us is they said, you know what, we don't ever want to do negotiations with doctors, hospitals, labs. That's your work. And then we talked about other things like, as you can imagine, we have medical policy, things that help us understand what should be covered, what shouldn't. And those are generally not the health insurance company's decision, believe it or not. They're usually the specialty societies that decide what are the right procedures for the right people. And we digest those into our company. So those are a couple examples of things that Collective is never going to do. And so we can do those things. And when we say we need maybe some help in the application development area of how to choose a high quality provider of healthcare versus a low or a mid level quality provider, that you guys can be the technology company that actually powers those things. So we've had I think a very good early start to being thoughtful about that division of labor. Oftentimes, I have worked with companies who say, we're going to focus on this piece of healthcare, and then we check in with them in 6 months, and they're focusing on this piece of healthcare, and then often nothing gets done. So I think if we can stay focused and really kind of check in on that division of labor, we have the opportunity to have more success, because we have to be mindful of what do we bring to the table. Well, we bring relationships with doctors and hospitals, we bring 18 million members, we bring a balance sheet of $100 billion, so we bring capital. So let us use the things we have, and you guys use the things that you have.
You guys know, as innovators, scale in healthcare sometimes really, really matters. So you're talking scale here in a way that otherwise a healthcare startup can't actually access, at least in the early stages itself. So, you know, one of the things that has been the most helpful, and I think will be one of the biggest generators of long-term success for this collaboration, is that ongoing, just working it forward, matriculating the ball down the field work in partnership with HCSC, to be able to understand where those opportunities lie and understand where we can actually play off of those strengths between both of our companies.
I know it's an obvious and you know, kind of an old phrase, but you know, follow the money, right? And what I mean by that is, in healthcare, figure out who's financing it, because It's not always obvious. And what I mean by that, all of us as individuals that access the healthcare system, we think we're the financiers. We pay our health insurance premium maybe out of our check. We pay our 20%, maybe we pay our deductible, and that is true. So we are part of the financiers of healthcare. We're the smallest financiers of healthcare. The 90% is paid by the employers. So when I hear good ideas, I say to myself, okay, those sound like the right ideas for individuals like all of us, but I also happen to be responsible inside our company for all of our relationships with those large employers, and I check with them. Like, is this what you want too? Because you're healthcare, and generally, we don't have to have the conversation. We have good enough intuition to understand, but we do need to think in care is delivered is very much a business to consumer, and that's a complicated, kind of way to think through how people actually access their health care.
Yeah, when you're an innovator in healthcare, you really do need to understand how the money works and where that opportunity is. When people are already spending so much on healthcare on an individual basis, it's hard to ask them to pay another $2 a month, another $15 a month, whatever the case might be. So find those opportunities to partner with a larger organization, with one that really does understand what that employer role is in healthcare, what the government role is in healthcare, who the people who are really paying those large bills at the end of the day for lots of really good reasons, and how you fit into that picture.
I'll leave you with this thought, and I think we're how they access their coverage. I tell people communicating employee benefits, healthcare to individuals, it is not rocket science. It's actually more difficult because people don't have time for it. And so if we slow down and take a minute to understand how difficult it is for consumers to understand it, I think we can see that there are tons and tons of opportunities, not only to improve that, but to root out waste in healthcare, because healthcare is super expensive. Part of it's because there's so much waste, and we want to do better on behalf of consumers and our members to improve that on their behalf. And people ask me once in a while, like, Kevin, who's your biggest competitor? My answer always is affordability. And if we don't solve this together, the affordability is going to just take it over.
Yeah, that's right. The focus on actually empowering individuals so that they can have the healthcare experience that they want to have is a very powerful place to start, and one that makes everything else possible at the end of the day. So be clear about what your goal is, be clear about where your opportunity is, and be true to your own reasons about why so many of us are in healthcare doing this.
Yeah. I wish you all tons of success, because healthcare needs it. And when you're working with a big company like us, really think about one team. Too often I hear us versus them. Think about one team and you'll be.
Thanks. Thanks, everybody.
Thank you to Kevin and Jennifer. As Kevin mentioned, we are going to allot some time at the end of this session so that we can have a Q&A, not only with the two of them, but for the rest of our panelists. So with that, I'm going to introduce Hillary. Hillary Sheeran is with the McKesson team, and she will be the moderator for our panel.
Thank you. Okay, good afternoon, everybody. This is called Healthcare Transformation, Igniting the Future of Startups. So what we're going to do first is we're going to do introductions. So each one of these panelists is going to tell you their name, the company you're with, the role they play, and then we'll do a little bit of a fun question. If there was a Netflix or reality show that described your life, what would that be? So we'll just start with you.
All right. Well, good afternoon, everyone. My name is Nalima Rajkumar. And like Kevin, I work for Healthcare Service Corporation, so better known to you all as Blue Cross Blue Shield of Texas. And I have responsibility for all of our commercial product development. So from concept all the way to commercialization, serve over 10 million members, both on the insured side as well as on the self-insured side. And in terms of, do you want me to answer the Netflix question too? All right. So this, I think the show that documentary that I really related to was one called 14 Peaks. Nothing is Impossible. So for those of you who haven't watched it, it talks about who decided that he was going to climb all 14 peaks that are higher than 8,000 meters. So they're largely in the Himalayas and Pakistan. And previously, that feat had not been accomplished. I think it was in 7 months. And I think there's a lot of parallels.
Okay, and here's why. There's a story. You're looking at my age. How does she know Queer Eye? Okay, I have children. So when I thought about this, the reason why I thought this was appropriate to describe myself is because I've spent my life as a parent and my life as a professional bringing together people with different views, different skills, different opinions, and trying to pull those out and highlight the best in all of them, particularly in challenging situations. You all can relate to that. So in order for me to make sure that this was legit, I did start a group text with my adult children. They gave me a thumbs up. I'm not sure if I was interrupting their lives or that was a genuine thumbs up. So a little bit of a story. So I thought, it's been a while since I've seen any of those episodes and love the Fab Five, right? But I decided to watch one before hopping a plane yesterday, and I watched Broken Spoke right here in Austin. And I thought to myself, this is legit. This is exactly, this works for me. This is what I love to do. This is who I am. But it was a wonderful opportunity because it was a needed and reminder and a needed reminder for me. In that show, they asked, how are you doing? And I don't do that enough. So it was a great gift knowing that this was a potential question for me to do my homework. And my personal takeaway, particularly in today's world, is to stop and say, how are you doing? And so that represents who I am and what I believe.
My name is Katya Hall, and I work for McKesson Corporation. I've been with McKesson for almost 3 years now, and I work in the data and digital organization. I am head of data product management, and I've been fortunate enough to work with Hillary in digital innovation, and really enjoyed partnerships with Capital Factory and startups. The show that represents me, I don't know how well it represents me, but we were joking backstage. I don't know if you have seen the show called Inventing Anna recently. I think it's a very complex show with a complex character. I haven't finished watching it, so don't tell me if she's really a scam artist. I don't know yet. But I definitely see complex moments and the whole imposter syndrome behavior and how she has to knock on many, many doors and prove herself. And sometimes I feel like, if you take innovation and you take it to different corners of an organization, and you're trying to position it, sometimes you get that imposter syndrome and you have tough conversations to try to sell it over and over again. So I'm going to go with that today.
That's great. Hi, I'm Dean Coleman. I'm Vice President of Business Development for a company called Worlds. We are not in the medical space. We're an AI company really focused on spatial computing and leveraging AI to basically be able to measure things in real space in real time. And so we started working with McKesson, really looking at the complexities of moving things around inside of a distribution center, moving pharmaceutical products, things that are highly sensitive around temperature, things of that nature, but using AI through that lens and trying to help solve those business problems through leveraging AI. So the conference is fantastic for us because it also speaks to leveraging technology, not because of cool. Kevin said it earlier. It's not something cool. It has to be measured. It has to be valuable. And so working with a client to understand how we can help improve your business, save margin on the bottom line is really what it's all about. So I've done startups most of my life, so the series of mine is Silicon Valley. I've lived a lot of those episodes. Yeah, I lived in Palo Alto during the boom, so yeah, I'm going with Silicon Valley.
Okay, awesome. Good ones. So the next one is really for Katya and Yelena. Both McKesson and Blue Cross Blue Shield have been working with Capital Factory for about a year now. So maybe just talk to us about that journey and how do you think that's benefited your companies?
Sure. So yeah, we started working with Capital Factory probably in earnest about a year ago, and we've enjoyed introductions to a great variety of very vibrant, dynamic, innovative companies. And I feel like it helps a company like McKesson really push the envelope and accelerate and find new innovative opportunities to reinvent who we are. Because as I was telling Hillary, sometimes after interacting with a startup and trying to embark on an innovation journey, you quickly discover, it's like after a good workout, you discover that the muscles hurt in the body, that you forgot you had those muscles. And as a big company, sometimes we forget how to be nimble and move quickly towards innovation. And working with startups has really challenged us to rediscover how to move quickly and rediscover how nimble execution can really happen once again.
Yeah, so I would say, a lot of our work with Capital Factory happens through our C1 Innovation Lab. So my colleagues Summer and McKay and Rachel. And I think the advantage is that there's so much happening in the healthcare space, right? I think in the morning we heard about $30 billion of investment. And there's a ton of new ideas. And so I think the relationship with the Capital Factory gives us access to what's happening in the market. So lots of new ideas. The C1 team works on sort of identifying what ideas might fit within our larger ecosystem and bringing those forward, making those introductions, really helping with some of the navigation. I think just like understanding what we as a payer might be looking for, right? I think Kevin explained that depending on where you sit in the healthcare system, you might have a different view. And certainly I think payers provide access to a large market to many of the startups. So I think we're at the beginning of the journey and really looking forward to seeing where it goes.
Okay, so the next question is for everybody. Just tell us a little bit about your journey, maybe some of the projects that you've worked on, and just how it has, met some business needs.
So I think we're going to talk about our relationship with Sapphire Digital. So the service that Sapphire Digital offers us is they are the technology behind what we call our provider finder. So many of you would have gone to your health plan and just looked for which doctor is in network, right? It's the #1 most used tool that we provide our members. Very complicated, from a back-end perspective, because there's multiple networks, there's employer business, government business, etc. And frankly, several years ago, we just weren't very good at it. There's a number of factors that go into that, and so we were looking for a partner, someone that would address our unique needs, but then also be nimble and flexible, because we are a large company and we do have many needs and we can be quite demanding. And so we've worked with Sapphire since 2010, actually, and have slowly grown. So we started with them with a segment of our business, and now they service all of our 18 million members. Along with that, we've gone beyond sort of just that basic provider finder function to offer additional, not just features to the initial platform, but also I would say products. So we launched something with them in 2018 that we call Member Rewards, So it really helps put cash in the hands of our members for actually looking at the cost and quality of providers and making decisions that are informed based on that information. So I think it's an ongoing journey. Right now there's in the last couple of years, there's been a lot of legislative and regulatory changes, something that insurers have to deal with a lot. One of them is called transparency and coverage, really changes the information that we have to put in front of our members, and so that is part of the ongoing partnership with Sapphire.
So I would say 12 years ago, we got really lucky because we were able to have a partner find a partner in HCSC. And for all startups, I would say find a partner who stretches you. Find a partner who stretches you. You will be better. But Kevin said it really well, and Jennifer, you did as well. You have to have the foundation, the fundamentals there. You need to be rowing in the same direction. Who is the ultimate customer? Who's the ultimate buyer? And understand that. And so even as Nalima said, the language and our focus has changed over the last 10 years, or 12 years, to be a technology company that allowed for healthcare shopping. It was really more of a check-the-box solution at that time. We needed to, as you all, look up, who are my in-network providers? What are my choices? How much will it cost me? Those are really fundamental, good questions to ask and answer from a technological perspective. What has changed and what we need to continue to drive, and that's the real innovation, whether you're a startup or someone who's been doing this 12 years. Member empowerment. Member empowerment. In healthcare, members are going to change the way the healthcare system works if they're given the right tools, the right information, and guided along to make the best decision for themselves. And rewards is a good example. But so our journey has been find a partner who will stretch you. Make sure that your company, inside your company, they know why you've chosen this partner and they will stretch you. You may need to staff them differently, support them differently, because they will be your innovation engine. And hopefully you will be theirs. And I think that's certainly has been the case with us. So it's been a long journey of understanding the business and working together to make sure that we're all driving to this member empowerment, member education, member experience that Jennifer referenced.
So my journey of working with Worlds Technology has been awesome. I'll kind of take a step back. So if you think about McKesson is a healthcare company, but first and foremost, it's a distribution, pharmaceutical, medical equipment and supplies distribution company. And what we do very well is buy product from manufacturers and self-distribution to pharmacies and really any healthcare provider you can think of, with patient at the core of what we do. So everything revolves around patient outcome at the end of the day. So when with the beginning of pandemic and especially going into vaccine distribution, so McKesson was the exclusive vaccine distributor for COVID-19 vaccine and all of the kits that go with it. I had an opportunity to lead the enterprise analytics response to vaccine distribution challenge and working with Operation Warp Speed. I get to see kind of in the trenches how the distribution process works and what are some of the challenges of the distribution process, some of the cold chain implications when you move an ultra-frozen vaccine across the country and getting it to the patient in one piece and without breaking cold chain and all of the FDA requirements that go with it. When we were introduced to Worlds, what these guys bring to the table is the ability to observe all of those processes using artificial intelligence, spatial modeling, and sensor AI. So from the very first demo, it became clear that this is groundbreaking capability that could really help us take our distribution smarts, our capability, which is the core beating heart of McKesson and what we do, take that to the next level and make it even more world-class and tighter in how we do it. So what we've been able to do is we partnered with Worlds, we introduced them to our distribution operations leadership, and I remember reaching out to our SVP of distribution and saying, hey Amy, if you could have 1,000 eyes watching your operations at all times using artificial intelligence and video feeds, what would you do? And she goes, go talk to my head of engineering. I was like, I can do that. So we connected and we found a couple of opportunities for us to quickly deploy that capability right there in distribution centers and observe cold chain operations. So from the time cooler, it's called the Blue Gaylord, enters the facility off a truck, it's being monitored from multiple angles of cameras, and the AI is aware of spatially of where everything is, where the entryways, what the pathway is, where the cameras are mounted, and it's clocking it, and it's putting it in a place and time, and it's monitoring standard operation procedure following engineering practices, and it will alert management, and there are little red lights that will come on if something is going off of procedure, off of SOP. So that was a very swift and successful implementation that we've done in a few distribution centers. And there's, as you can imagine, you're probably thinking already, like what kind of things technology like that can do. There's endless opportunities, and so now the burden is on us as product management to sit down and think through what are the use cases that are really going to move the needle on profitability of operations, because McKesson is really the middleman between patient and manufacturer of pharmaceuticals. We really don't want to be introducing any additional cost into that supply chain. We want to be extremely efficient, cost effective. So everything we do is to squeeze out the cost from cost of medicines and cost of care for patients. So, and these guys have been a great partner in that.
Well, I can mirror, I've been to your distribution centers, and there is definitely a lot going on. It is miraculous that boxes and shipments make it from point A to point B. These guys are experts. And so we come in with technology, and we want to make it better, right? We want to improve it, and we want to understand what you're doing today. And in some cases, you don't want to take what you're doing and just make it go faster, because if it's a broken process, automation is not the way to do that. You may have to take a step back and look at the overall process before you improve it. And so, we're a 3-year-old company, 150-year-old company. So you mentioned it, right? So how do you bridge that gap of, we think, oh yeah, we'll do that tomorrow, or we'll be there next week. Can we be there Tuesday? Like, we're not doing anything Tuesday. We'll be there. And they're like, oh, can we schedule this for 6 weeks out? So there's this energy that we want to prove ourselves. And I would say, from a startup perspective, that's one thing we've really hung our hat on, is not just selling and telling you what we can do, but let's get in to show you, because it's called innovation for a reason. A lot of this has not been done before. So we don't really know in a lot of cases. But we think, and we know our technology, and we know how we're developing it, so let us in, and we'll try to prove out those use cases. And we try to do it in 30 days. We don't try to do it in 9 months. We don't have 9 months, right? Let's go. And so they have been fantastic, and it kind of the bridge between the 3 years and the 150 is culture. It really is culture. We have a culture to go fast and do it tomorrow, okay? You have to find a team inside of a big organization. It's not one guy, it's not 3 guys. It's people that have a spirit of getting things done. And that turns into an innovation cycle that allows someone like us to implement a strategy that we can prove out, or fail. We might not be able to do it. But let's not take 9 months to not do it. Let's figure it out, get in and get out, and make it work.
Thank you. Okay, so the next question is for everybody. So tell us about some of the challenges that you guys came about, and how did you overcome them? So we'll start with TMD. We'll start with you guys.
Sure. So, 150-year-old organization. We've always done it this way, and then we open up the innovation office, and we want to do quick cycle, fail fast. We want to learn through experiments, and that means that we do proof of concept, and that, because it's touching our operations, it has to be dealt with a risk in mind, with cybersecurity in mind, and there are legal implications. So, of course, we've had to train that muscle of accelerating while keeping the risk guardrails, the legal and privacy and security guardrails on. So that has been a great learning experience for us, is how do we find pathways to innovation in an established enterprise that don't cut corners, but also bring teams together and find ways to move quickly, but without cutting corners. So it's been actually a great partnership with Hillary and our teams across all of those jurisdictions in McKesson to find ways to accelerate. That's been good.
I would just add, again, finding that partner that you're working with. Katya's been fantastic in the mountains, and some of the mountains I never see. I don't know they're there. She just takes care of it, and you know, I mean, real world things. You know, network bandwidth is slow. How do we stream 150 streams of video over a slow bandwidth connection? What do you do there? We have to flex. We wrote programs to throttle each camera. You know, I mean, we had to improve ourselves. So back to challenging, you know, finding a client that's going to push you. You know, we responded. We responded in 2 weeks, and we got that issue resolved. And so, just working through it with someone to overcome those challenges is very good. If you're a vendor on the outside of that inner circle of what's going on in corporate, and you don't have that champion, it's weeks of no email response. It's all those signs, you know, right? Nobody's calling me back. They said they were going to do it, they didn't. You know, we're 4 weeks out and no one's responded to my email. Those are the negative signs when you don't have that champion inside. And so from a startup perspective, you've got to find that mutual benefit, that mutual goal that you're all working towards the same thing.
And I would say from our perspective, you know, I've learned a lot along the way. One of the things that we didn't do so well in the early stages is we didn't align with the budget cycle. We're a technology company. We build things, we go fast. But we forgot who our partner was, in all honesty, because they have a budget and a capital budgeting cycle. As a technology company, we have a roadmap. That's the foundation of, right, who you are, what you're building, how you're going to innovate for your clients. Early days, we didn't align that. And so we bring to market these great ideas, and HCSC would say, fabulous, and our clients will love this. Kevin would test it out with his clients, and we just weren't aligned for funding. And so don't make that mistake, because you lose a year, and sometimes you lose 18 months. So I would say one of the lessons learned, as fast as we want to go, and that's what our partners rely on us to do, particularly in technology, continue to build and iterate and innovate. Don't forget, follow the money. You've got to make sure you're aligned with the budgeting and capital process.
I'll just build upon that and say, you know, it's funding, yes, but I think before you get to funding, you've got to share your roadmap. Right? I think too often, not just with Kyle, even with the other startups, they'll come with something which is fully baked and say, we've got this, you have to implement with us. And I'm like, no. You know, like, you didn't consider A, B, and C, right? And why didn't you come and talk to us? Because then we could have informed you along the way. I mean, at the end of the day, if we are working with someone, we absolutely want them to be successful, right? We've invested a lot of time and energy on our part in that relationship, on all the things that Katya and Dean talked about. And so I think having visibility into whatever your roadmap is, getting that from your partner, hopefully they're not tweaking it too much, but I think just giving them that insight can help with their planning and make sure that you're collectively more successful.
Just for one other thing on that, and it's okay if you've got a 24, 36-month roadmap, it's okay to say earlier on, baked. Further out, a little fuzzy. So don't be, I know that our teams are so afraid to go to HCS and other clients and say, but if it's not fully baked, but it's 18 months out, we have an opportunity to collaborate and to customize. And so that's really important. It doesn't have to be totally 100% spent, and it shouldn't be.
Yeah, but understand the selling cycle too, right? Because sometimes the selling cycle can be really long. So
our last question here, so we have time for you guys to ask questions. I mean, maybe anything more you guys would want to add about your journey together, strengths you brought to the table, or just anything you want to leave the audience with.
I think it's been great to watch Sapphire Digital's journey, right? So we've pushed them along the way. I'll let Kyle talk about, you know, how they've evolved. But from our perspective, I think just, you know, choosing the right partner is super important. And then we've helped them grow their business with other Blues plans, and that's reaped benefits for us as well. So I think, you know, goes back to sort of finding that right partner, someone that you're willing to make mutual investment in and grow together. I think that is super important. So, you know, before you sign that contract, really think about who you're signing with.
Well, and just the results speak for themselves, exactly what you said. HCS was our first client 12 years ago, and we were on a custom solution. We now are a full platform. We have over 100 million members who have access to our platform, over 60 health plans and TPAs. So they have really created our company because of all the things that Kevin said and Jennifer and Nalima. But we were rowing together, we were building together, we trusted one another, and we all understood what the combined strategy was. So, and just kind of the final point in our journey, although our company, our division is named Sapphire, we recently sold our company at the end of last year in October to Zealous. So who was a payments company, and now our new journey starts over. Same, different company, same mission. Really about member empowerment through technology. So we're really looking forward to our next chapter, bringing and working with ACSC there. So find the right partner, get stretched, but understand their customer and understand the selling cycle.
For us, partnering with Worlds, what these guys bring to the table is, of course, as a new organization, they're very nimble, very fast, they're extremely responsive, and iterating with us. I mean, the first AI models they trained in a matter of a couple of weeks. They modeled our 4D environment, created a digital twin of distribution center that we have within a couple of weeks. And I think the team had to catch up to them to keep up and move as quickly as Worlds were able to build. When we ran into the network bandwidth limitation, they actually went away, and they like to underpromise and overdeliver, and they went away quietly and iterated their product. They went and did a round of R&D and made the product work on fewer frames per second, so that AI could still do the work on fewer frames per second, so they could change the way the cameras were streaming. So that kind of nimbleness and quick response is what they brought to the table, as well as they're actually seasoned executives who have experience working with enterprise before, so they knew kind of what I had to navigate internally at McKesson, what I was dealing with. And sometimes it's like therapy sessions, talking about things.
Friday afternoon.
Friday afternoon therapy. So it's that combination of being innovative, quick, but also understanding how to work within an enterprise, how to navigate potential internal barriers, and how to make things happen nevertheless, in spite of.
Yeah, and I would just add, despite being technologists, we don't want to just implement technology for the sake of it, right? And so there's a lot of discussion and a lot of time sitting and understanding the problems. We don't come from the medical space. We don't come from the distribution space either. So we're walking in as technology experts, and the last thing you really want to do is just throw up technology on somebody, right? You need to understand what they need and what your capabilities are, and figure out what that matches in the middle as you go through that. We tend to like to bite off more than we can chew. Like, don't go for the layup, right? Everybody can do layups. Go for the harder things, because if your technology is any good, you're going to be able to figure it out. And we just try to be brutally honest the whole time. Also, if we don't know, we say we don't know, but we think, and let's try it. And you have somebody, and you build that trust over time. It really starts to really matter because things will change. You'll have bigger challenges, and that trust is really going to come back. So. That's important.
Okay, well, we wanted to leave some time for questions. Oh, I think it's good. Maybe the mic around. I'm trying to.
They're everywhere.
Yes.
I wanted to make a question regarding the last comment from Kyle. In the last 10 years in the tech industry, we have seen where there has been a tendency of concentration of power, where if you are a very successful company, start acquiring other companies, or you are acquired by a big one. What do you expect in the healthcare industry? It will be the future will be more the next year. The close future will be about decentralization of power and collaboration between companies, or the contrary, like what just happened to your company, that we will start seeing acquisitions and concentration of power.
My view is in the early kind of now, near next, we'll see more acquisitions. We'll see more coming together of best-in-class solutions to solve this healthcare problem has to be solved. And this is, to me, this is the time to solve it. We know that consumers now expect digital tools to shop for healthcare in a way they've never done it before. And I think that there will be a coming together and kind of a collection of companies continue to come together to build a better solution, a better technology experience. It takes too long to build it yourself, so I think we can get there faster. So I don't think it's going to be I think it's going to be in the short term. I think in the next term, we'll see those companies learn and grow together and then go on to their accelerate what they do together. But I do think the acquisition and the market, 2021 was a very big year for healthcare acquisitions and healthcare investments. Those are starting to come together. Those companies are starting to come together. I think we'll see that happen. In my view, probably the next 3 to 4 years, that will start to slow down to some extent. But there's a lot of great ideas, a lot of great innovations out there. And the funding is, it's a good way just to get additional funds to join another company as opposed to go out and raise additional capital. So I do think acquisition is going to be the primary way that we advance technology and technology companies. Anybody else have a different view?
Thank you. Thank you for a very interesting discussion. As most of you have said, healthcare is a very complex space, and at some point early on, most health tech startups ask the question, who's the customer, who's the user, who's the beneficiary, who's the payer? And in healthcare, most of the time, those probably are not the same entity, let alone the same individual. So I'm interested to hear your thoughts on navigating those complexities, and more to the point, sometimes the accrual of value is not exactly aligned to all those entities, and in fact, sometimes maybe at odds. So please, love to hear your comments.
I think you spot on, right? I mean, and I'll just use an example, like even within our company. So I focus primarily on our employer customers, and they're our customers, but our members their employees are our users, right? But in the case of the product that we have with Sapphire Digital, we also serve our government, sort of what we call our line of business. And so there is no, you might say the government is sort of the customer, but not really, and then you've got a member. So I think even within a specific product, you might have different variations. I think it's a question that we have to ask ourselves continuously. Who are we accruing the value to, right? I mean, it's about who's paying for it, but then, and what do they value, but then being able to really demonstrate where that value is accruing, whether that's to that paying customer or whether it's to the user. And I think what I've seen over the last several years, at least on the employer side, used to be all about, cost, right? Can you cut costs? Can you show me that you're saving me money? And I think there's a good segment now that are also interested about are you driving better outcomes for my population? And are you creating a better experience? Like, don't just throw another widget out there that, yes, it might save me $1, but it's going to make it that much more complicated for my employees to access healthcare. So I don't know that there's an easy answer, but I think we should be asking ourselves these questions all the time.
Easy answer.
It's healthcare. So would I.
That's why everybody's here, for the easy answers. Y'all are supposed to give them to
figure that out for me. Yeah.
Who else had a question?
Hi. In all great innovation and disruption, you're going to disintermediate the stakeholder in a lot of the cases. In our case, it's anesthesiologists. But when you're weighing the value of something and trying to determine, like, you sell to anesthesiologists, right? But if wide-awake surgery comes into more fashion in more places, they are out of the sedation business in those situations. So how do you weigh that when you've got multiple stakeholders, and what's better for the patient is probably not to be sedated, but that's the way the machine works.
I mean, also, again, like another one that there's no easy answer to, right? But I mean, I think it's oftentimes you sort of find yourself in like the classic innovator's dilemma. And I think to some degree, we all owe it to ourselves to make things better. And sometimes that does mean that we're going to potentially disintermediate ourselves, right? I mean, I think our relationship with Collective is a good one in that regard, right? To some degree. I mean, I think internally we have that question of like, well, why should we work with Collective? I mean, they do what we do. Well, they do some parts better than we do, right? And so I think that's, not to speak for Jennifer and Kevin, but I think that's part of the calculus, is if you don't try some things because you're afraid, you're probably going to be disintermediated in the long run anyway.
Just a quick question, whether it be McKesson or Blue Cross Blue Shield Texas, do you guys go by like a set criteria when you're looking at a startup to say, should we consider them or not?
It depends on the space. So anything clinical related, for example, we do have it go through a clinical validation committee. So that's not, I don't sit on that. It's just all our doctors and nurses, and they look at the clinical validation. And so that's kind of, I would say, step number one, right? Like, do they agree with the science behind something? And then if they agree with the science, then we look at what we call like value validation. So I think we talked about that earlier. Does this, we don't want snake oil, right? We want to make sure that we're delivering value. And so there's kind of value validation, I would say, is the second step. And then somewhere between those two, there's sort of market validation of like, is the market really looking for that? And that's really where my team comes in. But broadly, those are the three steps.
Yeah, and at McKesson, we always interact with our business stakeholders from the data and digital organization product management. We understand what are some of the key problems that they're trying to solve. Where do we have capability gaps that we would like to fill with external capabilities like Capital Factory partners, and then we connect with Capital Factory and we discuss that, kind of give them general themes of what we're looking for, and Hillary leads that process. So they will bring forward and recommend startups for us to engage with, and we'll talk with them. We understand their technology, and if we, if it's a successful match, we will probably evaluate it, so do a proof of concept, and there will be a value hypothesis. What is it we're trying to accomplish? And we'll prove it out to see if it really can plug in and solve a use case that we're thinking about. And if it's successful, then we'll discuss what does that look like for scaling. And
so I have a question for Blues and Sapphire team. I'm curious, when you guys, started with one section of your product of using Sapphire, how did you think about the expansion process? Was it like baked in advance, or like if it worked here, then we go X, Y, and Z, or was it like, well, this team needs it, this product of ours, people use that more, so we'll now implement Sapphire there? I'm just kind of curious. I mean, that might be too technical or too in the weeds, but it's interesting to me.
So when we brought in Sapphire, we were focused on using Sapphire for our employer customers, but there was a section that was using an internally developed tool. And this is where sort of like, inside baseball, right? Like, I mean, there's large organization, there's politics, there's sort of vested interests involved. And I think it took a while for us to just get everybody on the same page that, like, as a company, there's better value if we use Sapphire across the board. So did not happen overnight, right? I think it took maybe 6-7 years before we finally migrated everything to Sapphire, but it wasn't, wasn't just sort of click your fingers like it's working well. I think Sapphire really had to prove that it could deliver. And over time, I think we were successful. It's just, at some point too, it's sort of you can only bite off so much and chew it well, right? So you want to sort of slowly make things happen. As I said, like, this is a tool that our members use, and so it has to be absolutely right. There's no room for error when we get it out there. So it takes a while.
And I would add just the membership growth for sure, but then how the tool has continued to innovate. I mean, what Kevin said earlier is you go to the market and they enjoy some of the largest and known brands in the country in terms of who are their customers, and they push us. So our partner, health plan partner, ECSC, has continued to push us to innovate, and then we get feedback from their clients. So we now have, as Nalima said, we now have rewards on our platform. We've just added pharmacy in. So all of that innovation on the shopping and navigation platform is coming from internally within Sapphire, and also through their clients saying, this is what I'd like to see on the tool. How would this work? So we design it together, we bring it to market. So it's get the basics and the fundamentals right, but then listen to the market and innovate together, I would say.
I would say just like in general, like my experience has been it probably takes 3 to 4 years for something to kind of penetrate into the base. You start small, you've got like some early adopters, they want to see proof. kind of was brought up, but that's kind of the time frame, which I know is sort of, it's not a few weeks, right?
And guys, pilot is not a bad term.
Yeah.
A pilot is not a bad term. When you're a startup, right? Oh my God, a pilot. It has connotations that you're never gonna grow, get bigger, take that as a good thing and give it a big hug and make it grow. It's a seedling, so pilot is not a bad term when you're dealing with a health plan partner. That's what it said.
Yeah, and we're dealing with like millions and millions of people. I think that's the important thing, is sometimes you can lose track of that scale.
Any more? All right, thank you guys so much. Jennifer and Kevin, any comments on, I know the dialogue, questions? There's been great discussion. Thank you to our panelists. Anything either of you would like to add as we conclude?
On the great question about disintermediation, here's my singular thought after 24 years in healthcare. There is no room for garbage innovation. There's lots of innovation that's out there that's about feeding off the trough. There's no room for that. So the innovation has to be focused on getting that singular result about empowering people to have the healthcare experience that they want. End of story.
All right, well, thank you to our panelists, McKesson, Capital Factory, Blue Cross. We're really excited to have been here today and a part of this dialogue. I'm going to hand it to Michelle, who's going to give you instructions on what's next.
Thank you. Great group. Thanks, y'all. We are going to take a break, so be back here in about 10 minutes. And for our final session, which is partnered with IBM and MITRE.
Check, check, check. Check, check. Ooh, that's very loud. Check, check. Oop, little down lower. Check. Check, check.
Live when it's green, so.
All right, this is your 3-minute warning. If you need something sweet, we still have some cookies back there.
Oh, great, thank you. Yeah, of course. Testing, testing. Yeah, sure.
All right. Woo, what a fantastic day. I feel so lucky to be in this room and amongst everybody who is so passionate about health and making it better. I mean, that's a very easy word to say, but a very difficult thing to do. So thank you for sharing your expertise with us. And we've got some some more expertise up here on this panel. So this is the fresh approaches. It's startups bring new thinking to healthcare challenges. And we'd like to say thank you to IBM and to the MITRE Corporation. So without further ado, your moderator?
We're ready to go.
All right.
Thank you very much for joining us. We realize that we stand between you and happy hour, so we appreciate the attendance. You know, today we've heard a lot about healthcare transformation. We've heard about accelerating the approach. Today we really want to talk about how do startups really help transform that? How are the new approaches that they can take? How can we really integrate? Today has been fabulous. It's been great to hear everyone's passion. I think I will echo that in just saying that, you know, while I wish we hadn't had to go through a global pandemic, it has been phenomenal to see the level of innovation and transparency and the desire to really, across the board, no matter where you sit in healthcare, to really play a role in transforming. Prior to the pandemic, things that used to take years, we saw folks really stand up in weeks and really cut through some of the bureaucratic to really drive transformation and really see the future. The reality is, though, while we all knew that health inequity existed within our system, COVID really shone a spotlight, and some of the technologies that we meant to bridge those gaps, we actually saw widen that gulf. And so as we think about some of the solutions that startups and other entities are really taking to transform healthcare, I think we're going to really be very conscious of not only what does it take in healthcare, but what are the services that we need? How do we really step back and look at transformation and accelerate that? I think many of us, you'll hear us talk about what we're passionate about. I think from my perspective, my name is Kate Huey, for those of you who I've not met before. I lead IBM's global healthcare transformation practice. And one of the things that I really love about my job is that I get to meet providers where they are in their transformation journey. And everyone is in a place that's a little bit different. Transformation is this boil the ocean word, and it means different things to different folks. And just like healthcare, we need to meet entities where they are so they can engage in meaningful healthcare whenever, wherever, and however they would like to engage. And I think when we look at the pandemic and we step back, what we see is it really does take a village to drive transformation. So it's the providers, the payers, the consumers, family members, large healthcare organizations and startups that are really going to bring the promise of what the healthcare experience can be like going forward. So super excited to really be here and really be part of this conversation with all of you. We'd like it to be a bit of a discussion, so please feel free to weigh in and really make this very interactive. And I'll turn it over and let you also share your thoughts, and we'll go from there.
Thank you so much. I'm Linda Fischetti from the MITRE Corporation, a not-for-profit that works in the public interest. And it really has been a pleasure to be in the room with you today. When we think about what is trending next in healthcare, it's putting the patient at the atomic center of the healthcare system. And you've been talking about that all day. When we talk about what will be next in healthcare, we talk about really empowering individuals to be able to make the right healthcare information by surrounding them with a healthy information environment. And you've been talking about that all day. When we talk about what is going to be different for our nation, which is making sure that we're already mitigating the effect of the fact that in 2030, more of us will be over 65 than will be under 18. This is called a demographic crisis. And everyone here today is talking about how do we start thinking about healthy aging when you're still in the childhood, when you're still a young adult. So this has been a conversation of the future, this taking place today. And it just makes such sense that it is the startups, all of you that are making this happen. So it's a pleasure to be here today, and let me hand the microphone off to Kristen.
Hi everyone, I'm Kristen Valdez, founder and CEO of Be Well Connected Health. We help employers, health systems, health insurance companies, and retail pharmacies with their digital transformation, which, as was mentioned, can be very broad. So we help them to provide a reimagined consumer experience to individuals and their families, because we know healthcare is consumed as a family unit in the US market. But we are a leader in something called the patient right of access. So we help to collect and aggregate all healthcare data on behalf of an individual in one place, giving them access and transparency to their payer information, all of their providers, wearables, sensors, pharmacies, labs. We're uniquely connected into Medicare fee-for-service, the Veterans Administration, and giving consumers access and transparency not only to their health data, but then creating a truly personalized, down to an N of one communication channel so that we can be there for consumers when they need health and also help them upstream to tell them when there's something that they need to do for themselves or for their families, and then navigating them to care in a combination of in-person, virtual, and digital care pathways. So think of us as the single pane of glass to manage all of your family's health care in one place. For our customers, we are a decentralized and decoupled data model, open, secure data architectures. We're a FHIR native platform. We transact healthcare data across all of our customers. So now our customers have the ability to start working with each other. And that's because we believe it's going to take all different kinds of healthcare entities coming together to actually meet the needs of an individual and their family's healthcare. Excited to be with you today.
Hello, my name is Dr. Jose Alamo. I am the co-founder and COO of VemiDoc, a bilingual patient management platform. We're working in bilingual communities, primarily Spanish-speaking, and with the intent to expand into other communities. We were earlier talking just about health equity, and I think it's something that's just not in as an issue in minority groups, but really across the board, as we have a decreasing number of physicians available to the growing population, as you were just mentioning. And so as we came into our app, it was primarily to reach the Latino population. However, I think it's a common problem or becoming a greater problem.
It's interesting that you mentioned reaching the Latino population. We've done some work in mis and disinformation, and in doing that, we're able to take a very high-tech role in the background where we are looking at who is amplifying what type of information to a specific community, whether it's a Black community or whether it's a Hispanic community or a Latinx community. And so, but as high-tech as we can be in the background, that last mile is always the local community. So in the Miami-Dade County of Florida, it was the pastors that called us that were very concerned about misinformation being amplified unintentionally by members of their own community, and reached out to us to see what we could do in terms of making sure that they had the right counter messaging to be able to then amplify, because they're influencers in their Latinx community in Miami-Dade. Do you, are you working with things like that, or how do you do that last mile in the community?
That's interesting. I think that a lot of Latinos, and especially if you're Spanish speaking, you want to consume your healthcare in that language. It can be done in English, but you feel a lot more comfortable if you're doing it in Spanish. There's not enough Spanish speaking physicians out there, so we've got to find ways to help them communicate with their patients, which is what we do with our bilingual platform. So the physician can see the information they're giving their patients in English, and our patients can see it in Spanish. As far as disinformation, we're not in that realm yet. Mostly it would be in how the patient's consuming their health care, you know, primary care, chronic care illness, things like this.
Thank you. This has been an equity forward group today in the conversations that we've had. And Kristen, you were talking earlier this morning about how you are able to target very specific culturally appropriate programs to different populations.
Yeah, no, absolutely. So healthcare has been, in the history of healthcare, has been very paternalistic. It's very one size fits all. Employers, health systems, health insurance companies, all selectively curate and purchase point solutions, we'll call them point solutions, for the purpose of the fact that there's so many different categorizations in health. And then they deploy them to entire populations. So whether it's musculoskeletal or maternity or mental and behavioral health, there's a lot of really great companies in the space. But right now, everyone is selling into the same buyers in trying to get their costs covered and get out to populations to grow and scale their models. We've actually built a bi-directional marketplace that allows for startup companies to onboard themselves to our platform with open APIs and accessibility. And we're encouraging our customers to no longer selectively choose for their populations the solutions that they think are best, because we have learned that it really doesn't drive engagement. So let's take the case of maternity. You know, there's Wildflower and Maven and Mommy and Candlelit, but only one of those companies was created for Black and brown moms, which have very different outcomes in the health of our population. So if you're a buyer and you're looking for only one solution for maternity for the entire population that you serve, more than likely you're not going to choose a Candlelit, when quite frankly Candlelit is going to be more engaging to a portion of that population than any other solution that you select. So we're very big believers that consumers and their families should choose the solutions that meet their family's needs best, both from a convenience perspective but also applicability. And so we encourage our customers to launch an open marketplace full of partners and let the people choose.
I love that. You know, you've both actually talked a lot about personalization, integration, interoperability. Can you talk a little bit about what that means from a startup, where you've really seen success? You know, we've talked a lot about the modern open platform and really that village. Would love to kind of hear, as you think of the path forward and how startups are going to really come together across the communities to help drive the transformation. What does that mean from your perspective?
Well, I think one of the biggest challenges that we have is integrating with EMRs. And so a lot of healthcare is siloed, and we leave it up to the patient to figure out how, what they need. Patients often don't know what's been done in the past. And then when you throw language barriers in there, it can be even more difficult. I don't know how we get there with 360 million people. When we first started our startup, we thought we wanted to go after everybody, and you can't market that way, and people consume things differently. And so we took the approach of going towards Latinos and saying, hey, this app is for you, and so they could understand what we're trying to do. In terms of big data, is collecting the information, and knowing how to use that and redistribute it out. But I would say that the power of numbers is really where that everything comes together. But I still think you need the outlets in different areas.
And I'll just touch on that, and then we'll switch over. I love what you said about the data. The reality is your average consumer is going to create 300 million books of data over the course of their lifetime. It's not that we don't have data. It's that we don't have a way of actually making that data meaningful. How do we actually not only give the consumer the information they need at the right time, but also the clinicians? When we look at the AI-infused technologies or quantum, edge computing, 5G, all of those things are coming down the pipe, but we really need to create the level above that allows us to take that data and actually make sense out of it.
Well, and I think when we say we have the data, we, the people, do not have our data. My daughter has an autoimmune condition, and she has 17 patient portals. None of them are accurate. None of them talk to each other. And she had a near fatal event because 2 EMR systems couldn't share the same information. So putting the consumer and the person who that health data matters most to in charge of their data, where they can then become the sharer and provide that information to whomever they choose that could add value in their healthcare journey is important. But data is critical if we really talk about personalization, because for far too long we send the same message to everyone, right? Everyone needs to sleep more and exercise more, and you need to be gluten-free or soy-free or dairy-free or whatever free somebody thinks you might need to be. But the reality is that we are all in N of one. Our interests, our goals, our challenges, our problems, and our medical records and our insurance claims don't actually make up the things that we are concerned about in our health. There's a very big disconnect between the clinical side of the world, where people are concerned about metabolic syndromes and prediabetes and heart failure, where when you ask the average consumer what their biggest concerns are with their health, it is overwhelmingly sleep and stress. And so we have to merge those two things together and give consumers the choice so that they can take active care of themselves and their families. But without data, you cannot personalize. Right? How many of you, when you get 15 minutes free on the internet, go, man, I wonder if I become a caregiver if there's an app for that? Right? We don't shop for healthcare. Healthcare happens to us and we react. And so the reality is that where AI and data science can really be applicable to the data that can now be moved through the basic human right of the consumer in the US market. We can now use that to personalize services to say, oh, I see that you're concerned with your growing anxiety. Here's 3 solutions that might be useful for you. Or here is a physician who specializes in people your age with your concerns, and here's their quality outcomes and their cost. So bringing all of that data together can create truly hyper-personalized experiences that we've not actually deployed into our populations from a healthcare perspective because HIPAA. And we're so afraid of HIPAA. But the reality is that even if consumers want access to their medical records through things like email, which are not considered to be HIPAA compliant, if we, the user, say, hey, Dr. A, I really want you to give me my medical record, and I'd like it through email, that provider is actually legally obligated to send it through email. But we don't train or educate people in how to manage and navigate their own healthcare. But I think personalization is absolutely achievable now that consumers are in charge and can consent, which is a really magic word you're probably going to hear a lot about in healthcare over the next 5 years, in order not only to collect and move their own data, but also consent to be able to receive personalized communications the way we do in every other area of our digital lives.
So this is wonderful to hear, because up until this point in time, people would immediately be jumping in the conversation saying, oh, but wait, we only have 12% of the US population that is considered health literate. And it sounds like in communities like those that have been here today, we're past that, and we no longer need to use that as a constraint as we move forward. So it becomes absolutely fascinating to take what you're talking about, really putting the patient in charge of their own data with true data ownership. And then let's begin to run some scenarios about interoperability. No longer is interoperability a provider to a provider, or, oh wait, we just got the payers involved and now they can talk to my provider. It becomes the opportunity for an individual to share their information to get the care that they need. And the people that are taking care of them when they engage with the healthcare system are then able to have all of that information available. It's really a disruptor in our environment. I would love to, you said open architecture, and you said API. And I know there's somebody in this room that has not heard a word since that was said. So the modular open architecture, IBM has truly been a leader. We all saw when they bought Red Hat, we just assumed they were going to disassemble it, but they haven't. They haven't.
We didn't mess somebody up when we acquired them. No, it is. It's absolutely, I always kind of say, I wouldn't have wished a global pandemic on us, but I do think when I look at the changes and where we are, we've been talking about digital transformation for 10 years, and the reality is that 360-degree model of actually putting the patient in the center and creating almost that hub spoke of them having access to all their information, not just healthcare, but any of the social, any information that lets us look at the 360-degree view of a patient is so critical, and I really believe it's a game changer now. And that when you look at it, I usually use an analogy of like a beach ball. If you only look at a beach ball right here, you could argue for 24 hours that beach ball is red. It is not until you step back and you look at all of the colors of the beach ball that you realize it's multicolor. And that is what healthcare has to do. Too often we look at, oh, I saw my neurologist and my neurologist said this, but they're not talking to any of my other care team or my caregivers or my social services. And that 360-degree view is very different. I really like to talk about the strategy, the experience, the vision, and to me, technology is the enabler that brings all of those things together, but they are not what we should be leading with. That being said, I will talk about data fabric because, years ago we used to talk about, oh, we're going to put everything in the same data lake, or we're going to build huge data warehouses. That is not the solution, right? The beauty of a data fabric is we are creating connective tissue that no matter where your data resides, we're able to pull that up and create meaning behind it so that your consumers, your clinicians, your care team, whoever you as the patient have given permission to see that information, has access to that to really drive towards meaningful outcomes. We've talked about population health, we've talked about all of those things. It is not until we create that access to data and we allow patients to own their data and have an equal seat at the table that we are going to see healthy outcomes come to life. And I think that is so powerful right now if you look at some of the European communities, while we can't compare them given the size and the diversity in the US, what you can see is that as they have created these open modern architectures, enabled people to have access to their data, and actually creating a way to translate it, right? How often have we looked at, our medical records and been like, oh my God, if you don't have MD after your name, you're not going to be able to understand any of this. How do we create that translation so that we create those meaningful conversations where it really is a partnership? And so I think that is hugely relevant as we all think about how we're going to transform healthcare going forward, of really creating that partnership level and giving access to all the data, not just the healthcare data.
Yeah, I was thinking about just that. So the patient can control all the data, but at some point, I don't know how we take the physician out of it in terms of translating or that information for the patient. At some level, even if it's a neurologist, endocrinologist, there's still some level of need for a quarterback to be there. And we're trying to formulate those relationships, improve them at the local level, because we think they're really important, especially for the population that we're speaking with.
Oh, I don't disagree. I mean, the reality is that our healthcare landscape has changed quite a bit, even on the side of consumers, right? So we do want all consumers to have a quarterback in their care. I think it's really important, but 54% of the US population no longer has a primary care physician, and many of them don't want one. Convenience is going to be king, and I think that's why we talk about getting all kinds of healthcare organizations to start to work together and not to be so fragmented and siloed, is because consumers want to ingest healthcare when, where, and how they want to, whether it's in their home, at their employer site, in a retail pharmacy, which now, thanks to COVID, have the ability to practice at the top of their license. And if you haven't been watching, most pharmacies in the US have primary care embedded. They have telemedicine. They have health corners with connected devices. They now have home care. So we're really entering a time where I think we're about to launch into the Hunger Games of primary care, right? Because it doesn't look the same as it used to, recognizing that consumers really want convenience, they want text messaging, they want telemedicine. Yet when we go look for a provider online, all we really find is first name, last name, address, and phone number, and whether they accept new patients, and 54% of the time that's wrong. It's incorrect information. But from a consumer perspective, what do we want to know? Race, sex, years practice. Do they have good quality for the cost that I'm paying? Are they covered by my insurance? Will they text message me? Do they offer telemedicine or same-day appointments? So we need to think very differently in terms of digital transformation of the healthcare providers who take care of us to give better and different information. But when we talk about, some of the great work being done, especially, in the varying demographics, even location matters, right? So we were talking earlier about the fact that I had the great opportunity of building one of the country's first private Medicare Advantage plans focused on the diabetic population. And you could go into anywhere from, kind of Texas all the way up through South Virginia, which they lovingly call the diabetes belt, just because there's a lot of food deserts and a lot of other challenges. But you could pick up the phone, being a physician or a nurse, and talk to someone about their diabetes, and they're going to say, what are you talking about? I don't have diabetes. I got a touch of the sugars. Right? So it's not just about being able to review information at a fourth grade reading level. You have to actually get into the communities and understand, the dialects and the language and how healthcare is really delivered. And that really speaks even further down to that personalization to an individual.
One of the things that I'll just add and sort of switch a little bit is, I think it is going to be critical as we think about startups and the approach is, we are coming out of 2 years of a global pandemic. We have already had a shortage of physicians. We have chronic burnout. We've got exhaustion in the system. We've got inefficiencies in the system. And just as the consumers have been trying to navigate this, so have our physicians and our clinicians. The reality is they also don't have the information they need at their fingertips to do their job. And we sort of, when we rolled out the EHRs of the world, take your pick of which one you want to call, we promised it was as if it was the second coming. And it certainly has not delivered on the promise of making their job easier and simpler and giving them the information. I had a physician tell me not too long ago, I only have 30 minutes with my patients, and now I have to spend 15 minutes of it charting. This is not what I wanted, right? And so when you look at these solutions and these technologies that you're building, there is a huge focus on how do we help physicians do their job? How do we give them that information at the tips of their fingers, but then also how do we empower them as they are thinking through, how do I keep up to date with my training? How do I make sure that I have staff optimization on an ER floor? You know, my father had open heart surgery over the Christmas holiday, and my mother, who's 75 and is a retired nurse, was asked to stay with him overnight because they had such a shortage of nurses. Never mind all of the violations that probably caused, but they literally didn't have enough nurses on the ICU floor to treat the patients they are there. So I think there are any number of opportunities to extend the reach of the physicians. You talked a little bit about operating at the higher end of the license for pharmacists. The same is true for our physicians. You know, prior to COVID, you know, there was a lot of reluctance in the medical community to really embrace digital solutions. And now, fast forward, we have more acceptance in the last 2 years of digital solutions than we probably had the entire 10 years prior, because they're seeing the vision of, wow, not only am I operating at the higher end of my license, I'm doing what I went to medical school for, right? I'm keeping folks out of the ER, I'm saving lives. And what that has allowed me to do is almost triage and be able to much more effectively manage my practice. And so I really think as we come out of this, there are so many opportunities for startups to really engage with physicians differently, just as we're looking at how we're changing the game for consumers. And because I think of consumers, to me, a consumer is whether you're the patient, the family member, the caregiver, the clinician, it is whoever is consuming and wants to consume healthcare at that point in time.
No, I think that's actually a really good point. You know, we have health systems that we work with, and I'll give you kind of like a tale of two systems. You know, they each have 400-person call centers. 89% of those calls are booking an appointment. Long gone are the days of picking up the phone to make an appointment, you know, with the doctor. Why? Because they're open 9 to 5, right? And what do we do from 9 to 5? We work. Maybe you can call during lunch. Guess who's closed during lunch, right?
Yeah.
We make it really hard, but we live in a world where you can literally order a pizza and watch it go into the oven, come out of the oven, get into the car, come all the way to our front doorstep and ring the doorbell. But we have to ask a friend for a recommendation from a physician because we can't find them online and they're not accessible when we can. So when we think about these systems, right, one of them said, okay, I don't want a 400-person call center. I want to get nurses back into clinical care and into the hospital because we have such a staffing shortage. And the other said, I do want to maintain a 400-person call center, but I want them actually solving the hard problems. I want them connecting, you know, consumers to social determinant, you know, and community resources that can be helpful. I don't want them spending their time booking appointments. So I think startups have a tremendous opportunity to help make the lives of physicians easier, but you also have to remember not to have them have to use multiple other different disparate, you know, fragmented solutions. So it's great in that this invention of the API in healthcare, I like to say it invention because it's brand new to everybody in healthcare, is the reality is that we can now bidirectionally integrate into the EMRs. We can make things easier. We can sit on top of them. We can automate functions and desk jobs. And quite frankly, now is the perfect time from a health system and provider perspective to offer those solutions because we do have such a shortage of doctors and nurses.
So back to that API, because there's some developers in this room that keep hearing you say that. How do startups engage with you? And what advice would you give a startup that wanted to come in through your API?
Yeah, I mean, I think, first of all, FHIR is going to Fast Healthcare Interoperability Resource, spelled FHIR. It's like the new HIPAA, you got to spell it right? And so I thought I'd, to help, but FHIR is going to be the way that healthcare data transacts across the world. There's already multiple countries that are adopting. The majority of the US population can now access not only their clinical records, but also their insurance records directly through FHIR-based APIs, but there are implementation guides that are out there for all kinds of things like social determinants, smart benefits, eligibility. But APIs actually allow for systems and companies to start to develop with other companies. One of the things we say is in our double-sided marketplace, we encourage startups to come and sign up and onboard themselves. The thing that we ask from a consumer perspective is that you you develop against our APIs so that the user doesn't have another form to fill out. We already do a digital identity verification that is IAL2 NIST level certified, which is more secure than HIPAA from a digital perspective. But being able to then say, oh, I am interested in Candlelit or in Maven or in Mommy. So when we launch off through that single pane of glass, we don't want the user to immediately be dropped into a form where they have to fill out another registration form, have another login and password, but that they actually accept the token for the digital verification credentials so the user has a seamless and frictionless experience. So I would just encourage startups, my kind of word of wisdom is don't assume that you're always going to operate independently and that everyone's going to download your application. Think about how to interface with other healthcare applications. And the biggest example of that I can give you is that if you're selling into health plans and health systems and insurance companies and, pharmacies, they already have a mobile application, right? And so even if it's not working for them, and they will all tell you that they are not working for them, they're not going to just drop their 80 million registered users and start over with you. So think about how to work together in order to embed your solution seamlessly and frictionlessly inside of theirs so it can help them distribute you more easily.
So does your company have APIs with Cerner and Epic?
We do.
That's great.
Yeah, so there's multiple ways to interface with EMRs. There are public APIs, there are proprietary APIs, all the way down to Epic has a program called Data Tiles that they're actually phasing out, which just means they're dropping you back into the portal. But there are multiple different ways that you can interface bidirectionally into the EMRs, because I think EMRs, while originally trying to tether people to portals, I like to coin, portalitis is the diagnosis code that our current technology standard can actually eliminate. But you can't keep tethering people to portals because our data sits in at least 78 different disparate places. And we now have portals and passwords for every doctor, every hospital, every lab, every radiologist, every employer-sponsored health and wellness program, which is like 18 to 21, depending on the size of your employer, your HSAs, your FSAs, your insurance carriers, which change on average every 2.5 years, and now what is more than 300,000 digital health applications. We can't continue to tether people to portals. And so it is important to bidirectionally integrate with the EMRs because, as has been talked about, getting the right information to the provider at the point of care is critical. And consumers want that. How many of you don't want your doctor to see the relevant health information when they treat you? I think we all want that. Now we have the right to direct it, so we have to integrate with the point of care systems that are offered today.
Absolutely. I mean, can you imagine if you had to go, like I'm flying tonight, if I had to log into a different portal to check my bag and then log into a different portal to select my seat and then log into a portal to actually board the plane. I mean, the days of that happening are over, right? And coming out of COVID, the simplicity, the ease of use, the convenience, that is what is expected. And we are continuing, the last best experience that anybody has anywhere is now their bar for experience going forward. And so when they look at, I consider finance pretty complicated, and I can't tell you the last time that I went into a bank and talked to somebody. I can't tell you, my retirement funds, right? I think we have, to your point previously about the line for HIPAA is here and we're staying all the way back here. We don't do that in any other complicated industry. And I think consumers and clinicians are now at the point where they're like, okay, we've gone through a global pandemic. We need to fix healthcare. We need the transformation to happen. And it absolutely is going to take a village. If you look at what Amazon Health is doing with their telehealth, if you look at what Walmart Health is doing, if you look at what CVS Health is doing, they're all looking at how they are going to tackle portions of their population to meet their consumers where they are, but they can't drive innovation on their own. And so they all, I will say from an IBM perspective, when I joined IBM about 4.5 years ago, I really feel like we gave lip service to our partner ecosystem, that we said we worked with everybody, but we really didn't embrace that. Today, coming out of a global pandemic, we absolutely are working with our clients and embracing whether it's anyone that they are partnering with, but also our own partners and our startups, because we realize we can't do it alone. And I really think as we move forward and listening to all of you, the path forward is really the village approach.
Right. It's interesting how we're talking about APIs technology, and some portion, maybe, I don't know, 40%, making this up, is still done by fax. So physicians will still fax each other, and because of HIPAA, and that's what they're afraid of. I forgot my point.
I'll riff on her talking about disruptors in the market if you want me to take on for a second. Okay, so you're talking about the CVSs and the people that we never knew. Like, who ever anticipated that Amazon would actually have a pharmacy? Like, it didn't make sense to us just 2-3 years ago. So one of the spaces that I'm looking and watching is space health. So this week at HIMSS, I have a session where we have people who, like Milton Chen, who from VC in California, who is providing telehealth services on the International Space Station. What do you think we can learn from him in terms of the human-machine interface and the ability to create, opportunities to assess? Yes, we're talking about wearables today, but there's also implantables, there's sensors. How do we create an ambient AI environment where when you are completely, and these are the words of my colleague, Dr. Einar Sawyer out of the UC space program at San Francisco, when you're completely untethered from the U.S. healthcare system or any healthcare system, when you're doing deep space travel, then all of a sudden you really have got to think about not diagnosis treatment, but it is all the way back at using sensors to watch eye movement, to watch gait, to really detect that deviation from the norm well before you even get out of that spectrum of wellness, maybe a little bit tired, and then into sickness. And so that's going to be an area where all of us that are trying to empower individuals will hopefully have a wonderful technological exchange as we learn from each other about how to keep people on that wellness cycle.
Yeah. What I was going to say was about health education, how important it is. The conversation has been, feels like the patient is a highly driven individual already to want to be the center of their healthcare, but some of our sickest population don't understand their healthcare. They need a lot of hand-holding. And so, that has to come through the healthcare provider. And so having many touch points, whether it's through apps or emails, not people have faxes at home, so you can't do it that way, but there has to be a constant communication between the patient and the provider. And, so education at that level is really important.
Then really changing that 12% health literacy, right, with personalized, as you were saying, just-in-time education that we're learning from AI algorithms about when to intervene, how to intervene to get the positive health outcome.
Well, I think it's also important because you talk about, the communication with the patient. But let's not forget that the patient is not always the person who's going to take action in their lives. We have a concept that we call the health circle. Historically, insurance has made that people who are covered under the same benefit. But we know that it could be a neighbor who helps provide transportation to an appointment, or a caregiver or care manager, even at a health plan that somebody trusts, right? It should be up to the consumer who they share their information with. But when we think about the U.S. healthcare system, we absolutely consume healthcare as a family unit. There typically is one healthcare CEO in every family. 86% of the time, that is a female. So you need to get that information to the individual for all of the people that they caregive to and that they are a care partner to, whether it's taking care of our children, to our spouses, to our parents who are now living generationally much longer than the generation prior, but also aging at home, where we don't always have access. And COVID absolutely showed us that sometimes we couldn't get into those retirement communities to go to the doctor with mom and dad or grandma or grandpa. But even in our, bilingual populations, a lot of, first generation Spanish-speaking kids are actually the caregivers, or I would say first generation US born to our Spanish native speakers. The kids are actually the ones who help to bridge the gap between providers and individuals. And so it's important to give information, notifications, and nudges, not just to the individual, but also to all of the people that are caregivers and have impacts in their lives.
It's so true. I know I'm the healthcare family CEO in my house. My husband hasn't made a doctor's appointment in 20 years. But, I do think about that in terms of being the sandwich generation, where not only am I managing my children and my spouse and the family dog, but also my parents. And the reality is, as they are aging, and we think about consent and technology, elderly care solutions that are going to enable folks to stay in their home longer in a way that they opt in, right? Because the reality is we can censor a home now, which I know sounds a little big brother, but if it enables our parents to live independently and stay longer, and then it's customized, to your point, to communicate to me or to a neighbor or to family members based on certain things that the sensor sees, right? Like window left open, or hey, dad didn't take his medication, but is also smart enough to know what sensors need to go, what alerts need to go right to the care team, or if the fire alarm goes off, by all means, alert the fire department, right? And so as we are looking at technology and going up onto these IoT platforms and creating those very personalized experiences, yes, there is a big brother effect that people do voice, but the reality is that ability to stay at home, consent and convenience and simplicity allow people to opt in. And I think we need to be, just as you talked about the doctor not going away, that's absolutely true. And it is customized and it is personal and it is different based on who we're talking about in the family, right? As the family CEO, I am very comfortable having a virtual health visit or doing a urgent care visit, whereas for my child, I may say, no, I'm going to opt in to drive across the bridge to go to Children's, or I want to see somebody. And I think we have to really start to recognize, just like there are different segments of the population, there are different needs even for the same individual. And we have to give that customization and personalization and ability to opt in, depending on what that is. And I only see that becoming more critical as technology really enables us to have much longer, healthier lives, but operating on our terms.
At this point, should we
Open for
it
questions? The bar's almost ready, so I figure now's a good time.
And if you don't ask questions of us, I have one for you.
If you can speak loudly.
Oh, no, I get.
Never mind.
Sorry, I was so intrigued and paid attention. I wasn't paying attention to getting the mic.
To us or to the bar?
No, to you. Oh, really?
Thank you very much. This is really interesting. We've been talking about consumerization in healthcare for decades. I'm just an observation. I don't think I heard price transparency once today, which is weird because a couple of years ago that was all the rage. My big question is, who pays for this customization? Because when you talked about having all these different options for maternity care, if I'm in a narrow network, and I see these options, but my insurer isn't going to fund those, where are we in the road to having defined benefits where my insurer only says, well, you have to go to this group to, like a defined contribution where they're like, here's a chunk of money, you get to pick whoever you want to go to. And what are the barriers to that?
Oh, there's so many. So I'll touch on that one. This is a big soapbox item of mine. We've been working with a lot of big payers, I would say the incumbents, but also some of the smaller, younger, companies aim to disrupt. And one of the biggest things that we tell them is, man, it would be so incredible if your gold, silver, platinum had a benefit that was a pool of money where consumers could actually choose which solutions they find valuable in their own lives, because it would increase engagement. When we think about, kind of your earlier conversation on price transparency, it is very early days. Most people don't recognize, but January of next year, all commercial plans in the country will be obligated to provide the equivalent of an evidence of benefit or evidence of coverage. Basically, what is it going to cost you out of pocket against your benefit and your network in order to have this service for everything other than emergency room? So big payers across the board are actually working right now on how do they take this opportunity where they have a legal obligation to provide price transparency to start to add things like quality. to navigate to the top quality, lowest cost docs, but at the same time, be able to fulfill their commitment and also start to inspire and drive loyalty. So the move to value-based care is actually accelerating. And I know in healthcare we've been talking about it 10 or 15 years, but it's accelerating for a couple of reasons. And largely it's because the federal government has made a number of changes from a regulatory perspective, which would be a whole other topic. But at the same time, programs like direct contracting were created. So Medicare said, look, you know, I want the 54% of people who are not fee-for-service Medicare, who are not in an MA plan, we're now going to give the consumer the right not just to direct their healthcare data, but their healthcare premium dollar to providers. And they are favoring provider organizations. And so for the first time, healthcare has to compete on loyalty. And that's where the consumerization of healthcare is actually going to start to come to fruition. And that's because if I want to keep you and your premium dollar where I finally get paid for the service, for you not coming to see me, because I get to be in the margins and keep you healthy, then I need you to think that I am the cat's pajamas or the cat's meow or whatever that metaphor is. But basically, I need you to like me. And if you're going to like me, that means I have to communicate better. I have to provide you all your services in one place. And we can continue to shift into those value-based arrangements. But even the new entrants into primary care are really interested in taking risk. So the only way to really manage risk is to have access to that 360-degree view set of data, but the consumer really needs to be the one to consent it. So I think trust and loyalty are really important. But to answer your question, we're seeing a sense of urgency that in my 30 years in healthcare, I've never seen.
And I'll offer sort of another perspective on that as well. The direct-to-consumer healthcare is real. I mean, how many people have already bought for $950 the Grail test by the Gallery test by Grail that will tell you whether you have got 60-some cancers just by looking at the DNA that's floating in your bloodstream. So it's just a blood test. And oh, by the way, then they they try and figure out what type of cell it comes from. Yesterday with HIMSS, I was at the Lake Nona with startups, and there was somebody who is about to come to market with $150. They're called Age Rate. You can get in their beta. And they are going to look at, and I don't recall exactly what it is, but what is your biological age and how does that compare to your chronological age? And then over time, they'll be able to make recommendations about how you can pull those two things together. So for those that can afford it, so I realize
I was going to say that $950,
I
was like, well, that just took the number down.
Those that can afford it, and then what are we doing? We're continuing to increase that gap for disproportionate populations that have received disproportionate, negative impacts of our healthcare system.
But I think that's where the pressure has to come in on the health insurance companies, or there's opportunity to disrupt the existing health insurance companies. When you think about things like obesity, right? I mean, it's a huge problem in the US population. Metabolic syndrome, I mean, the #1 killer of male and females is heart disease and heart failure, followed by, diabetes and other conditions. But the most current medications that actually help from a genetic perspective are not covered by insurance. Mm-hmm. So instead of it just being, behavioral and lifestyle, which is about 25%, of the overall factor of obesity, we are still paying for the treatment after people are sick instead of getting upstream and helping them to avoid it in the first place. So being able to bring down the cost of these advanced tests and have them covered by insurance, expanding insurance coverage, for the population, but also being willing to become early adopters of medications approved through the FDA in order to create prevention of these conditions. It's in the best interest of the insurance carriers, the employers who pay for commercial insurance, specifically Medicare and Medicaid, which Medicare is going to be bankrupt by 2026, so they should probably, get on that.
Yeah.
But
Social Security too.
Right, but the reality is that we're so used to all of this evidence-based care, which means that we are waiting for years and way too many of them to figure out what is working and how do we align people. And while there's really good practice in that, we're going to have to start getting a little bit more brave, and we're going to have to start being early adopters. And now, because of what we witnessed in COVID, we know that we can. Mm-hmm. We just have to get brave enough to change the way that we are building our benefits and what we are paying for in order to make a real dent. And the insurance company who comes to market who adopts that is going to reap the benefits, not only from a loyalty and trust perspective, but overall medical loss ratio financial impact as well.
Absolutely, because there's such a desire to change right now. I think we've been so reactive for so long, and we have sort of that, three-legged system, and prior to COVID, they really weren't working well together, and they're still not right now. But I think there is a desire to work together, and I think there is a desire to move towards more proactive. The risks of the large payers have really started to say, wow, it's so much more expensive if I wait till the population gets sicker. And with an aging population, there's a change. I think if you think about sort of the changes in legislation that are coming down, and how that is going to drive changes in payers' behavior. And then you also look at the uninsured and the underinsured, and we start to partner with different partnerships, right? Like Walmart sees 95% of the uninsured and underinsured in this country. How do you partner and make healthcare consumption easy for them? Because it shouldn't be a $950 test. Right? It should be that when we look at the way healthcare is in the US, it ends up costing far more if we don't catch it early. And so when we look at some of the lessons we can learn from other folks that have entered into very proactive healthcare, how do we do that? But then also, how do we, as we look at consumerization of healthcare, how do we also use gamification and loyalty and stickiness in different ways, right? Because today, I know the apps that I immediately look at in the morning. I know the ones that I will look at when I finish speaking. How do we create healthcare solutions that actually but make consumers want to engage in their healthcare? Because I think that is really lacking today.
Yeah, the insurance companies have a big incentive to keep their patients healthy, as we just talked about. At the county level, and I'm from El Paso originally, and so if you do a heart surgery, a knee surgery, and there's a global fee, and so that patient will continue to be seen during those 30 days. If the patient isn't contacted often, it could be an infection on day 35, 36, or 60. That knee or heart will have to be redone again, right? And so if we're being in constant contact with the patients, we can catch these things early. It saves the state money, the city money to do it. Not that we're doing it for money, but we also don't want to be wasteful. So constant contact is really important. Now, these surgeons whose operations are being redone over and over again, insurance companies will begin to decrease their pay, their reimbursement, I should say. And so you'll see quality go up even just from a competition standpoint.
Agree. Any other questions? Up in the back?
I was going to say a quick one, more quick.
Hi, thanks. I wanted to go back to your comment that you made about space. And as we start doing more space exploration and we move into an environment that's more austere, a little bit more disconnected, a little bit more remote, what kind of technological advances and what technologies do we need to embrace in order to make that remote physiology diagnosis for potential new ailments that happen because of long-term exposure to the space environment, especially as we're all doing more exploration? And how does that differ from the remote medical technologies we have now?
That's fascinating that you bring that up. BioIntelliSense is a group that has a biometric monitor. You put it on, it stays on for 30 days. And they're currently using the Antarctic as an analog for space. And so we are all trying to figure out what is it that will make these strong enough. And we also know that when you're working in space, you have very strict weight, physical space, radiation, noise, vibration, very specific design constructs that are not applicable here on Earth at all. Plus they have to work in microgravity, it goes on and on. And so from that, we're gonna get amazing amounts of innovation. And as we begin to do that, we all use Velcro every day. There will be a healthcare Velcro that comes out of the design constraints for space, for health devices and sensing. So we're all looking at that, and you're 100% right that we need to be paying attention to it.
Well, even some of the companies that started to really, even prior to COVID, but really sped up in COVID, where you could buy a kit and it would send different things so that you could attach it to your phone. I mean, I have 3 young kids. The number of times I went to the pediatrician in the first couple of years just to make sure they didn't have an ear infection, where I just needed somebody to look in their ear and be like, yes or no. And so I think as you think about sort of some of these apparatuses, some of these things that are actually extending the reach of the physician into the home or into space or into, different aspects of being able to consume your care. Because if you're on vacation, the last thing you want to do is leave, the beach to go do this. So how do we actually allow folks to create like those technologies? And if you think about not only the sensors, but the different devices that are now going to be compatible with our phones and our computers that allow us to basically create the doctor's office no matter where we are, I think that's a lot of the things that we're also seeing really extend that footprint and key learnings about, well, what can you do remotely versus what do you really need to go into the doctor's office? And I think that definition has drastically changed from COVID. I think before there were very few things that we said, yep, this is absolutely a qualifier for virtual health. We would say like, we don't have the ability to do that at home. And the pandemic really made us start to think outside of the box and start to really engage with different types of technologies that would extend the reach.
Hi. So I have the, arguably the best job of the day. I'm going to open up the bars. But before I do that, I want to thank everyone that came today. And, I think for me, listening to all these great sessions today, the recurring theme is when you're approaching problems like health equity, it truly takes a village, right? And, the group that put together this program today is a village, very disparate partners. AWS, IBM, Baker Botts, McKesson, Blue Cross Blue Shield, MITRE. Did I forget anyone? Did I get them all? I think so. So those are the types of partnerships that we need to solve problems like this. So I would encourage everyone to keep that in mind when you're facing kind of these insurmountable challenges. So on behalf of the entire Innovation Council here, thanks to the Capital Factory, this was wonderful. Please eat, drink, be merry. We've got some of our collaborators and partners that have table stations. So KidsX is here. We've got LifeBridge. We've got AWS Startup Ramp. And I encourage everyone to go find Vina and try NeuroRehab VR. I can say personally, I had a unit at my house for a while, and it's really awesome tech. So thank you, everyone, and enjoy.